Okay, so if I could have your attention for a moment, please. So, my name is Ole Ljungqvist. I'm the chairman of the board of the European Nutrition for Health Alliance, and it is my great pleasure to share this very special session on EU4Nutrition with two phenomenal colleagues. We have Michael Choudakis, who is the chairman of the Greek Pen Society, and also Fani Paverdi. She is the chairwoman of the Dietetic Association here in Greece. We have a phenomenal program for you today. I'd like to welcome all of you here in Athens who are present here with us, but we also have an audience who are on the internet watching us through a live streaming. So welcome to all of you as well. So we have a two-part program this morning, one with a bit more Greek focus, and then we have a bit of an international session following a short break. So just to kick this off, what is this all about? It is actually translating the knowledge that we have from science into policy so that it could foster also practice in the end. That is what our mission is in the European Nutrition for Health Alliance, and that is what we will be talking about during this session and during this meeting. What about nutrition care in Europe? I think we have still several challenges to meet. We've had a very interesting discussion this morning with the patients discussing their point of view of this. And I think this is where our target obviously is towards the patients, making sure that we have the best possible care. But we also have to understand that there are other stakeholders in all of this, the professionals, but also the politicians, the decision makers, the people who are there to manage our money that we're putting into healthcare in the end. So there's a balancing here. And in all of this, I think policy is vital and very, very important. So if we just briefly summarize where we are today and what is the problem, why are we even discussing this? It is because disease-related malnutrition is prevalent in Europe. We may be the richest part of the world, but it is still a lot of people who are suffering from unnecessary undernutrition, partly because of their disease, but for other reasons as well. And one of them is that we're not getting close enough to treating them well. And we know from many, many scientific reports that nutrition and nutritional care and managing metabolism of the body of our sick patients is a key factor in the care of both acute and chronic disease. So here's something that we really need to do. And we also know from many studies in different countries that actually delivering that care is very, very cost effective. So there's really no good reason not to do it. I read a paper in JAMA just the other day bringing up the fact that in medical schools, this article was about the United States, but it's the same in many places in Europe, although I know we're pushing a lot for that within ESPEN and other organizations. The teaching of nutrition, the basic stuff, is very rudimentary, very poor. So here's another example of what we can do. So all in all, I think that nutrition and nutritional care is really a forgotten care element. And this is something that we got to do something about. And the way we can do things here in Europe is to work at the bottom with all of us who are stakeholders on the floor, if you like, patients, professionals, scientists, and so forth in different medical associations. But we could also try to reach to the top and try to make it possible to have nutrition as given a seat at the table at the EU. so that it's always there, right? And if we want to foster and move things within the EU, for us who are working daily with patients and so forth, in hospitals and other care facilities, we're not really thinking too much about how things work up at the EU level. But there are different parts that all play a very important role. So we have the European Commission, of course. They run things, but they have to get decisions and approvals from the European Parliament. And then, of course, we have the Council with all the representatives from all the different countries. And they work together to adopt legislation by deciding together. It's very complex, but I think it's very democratic. And in a way, with the world changing a lot these days, I think we should be happy that we do have some foundation to lean on for this, actually. So if we are going to influence people here, we need to understand the setting of the scenario to begin with. And this is where we can come together and work together to try to approach people in different positions in different parts of the EU so that they will get an understanding that this actually is very, very important. And the way that we have been approaching this with the European Nutrition for Health Alliance is that we have been gathering stakeholders, different stakeholders, who all play a part in the care of the patient. And many of them may not be so obvious for us, and many of them we normally don't meet as a clinician, for example. I don't talk to people who are in the insurance business or politicians very often. Fortunately, sometimes we have good clinicians getting into policy and can help drive it there. But that's not always the case. But if you put people around the table and present them with the facts, at least in this part of the world, people start to react to those facts and start to direct their interest and move things with the things that they can contribute with to move it in that direction. I think we've seen that happen in many countries. So if we want to approach the European level, it's important that we have many people from many countries influencing and presenting the same need to the people so that they can actually have a bit of strength to move this forward. Popping up as one organization is going to be very difficult, and we found it very, very, very fruitful and very rewarding to push the agenda with many stakeholders standing behind the same message and the same need. And we've been using that model at the national level and the regional level to build the interest and the focus from these people so that when they go to the EU, they can actually find somebody else from another country to do the same thing. And this is how these circles actually work. Because once you get it adopted at the top level, they will then spread it to the countries where we perhaps haven't been as successful. But with legislation, with focus at the top level, it will go to all the countries, and we can continue to build like that. One thing is very important is this never stops. Because we have, in our democratic system, we vote every now and then. We change half the parliament. We change a lot of people in these positions. So we continuously have to work on this. And if we've done a good job at the ground level, it will be easier to move it with the new people that are coming in as well. So if I just exemplify how we've been working a little bit, we're now doing the EU4Nutrition live session, which is a way to really spread the message of what we're doing and involving people in this particular meeting from Greece, which is our hosting country, of course. So we will get a bit of flavor of the situation here, which I think is very important. We've been involved in different plans that are being pushed by the EU agenda, of course, because nutrition is important in any healthcare situation. Basically, it's not difficult to actually get a foot in to the room where these things are discussed, whatever it may be. We're also involved in several EU projects And we have member and partner projects that are ongoing. We're working with the WHO and other organizations that can help us do that. So that's at the top level. But at the same time, we're also making sure that we're present and working with many of you in your different countries to run policy seminars, to talk about how do we do these things and what have we learned from other countries and how can we do things, what are the issues in your specific country. And of course we have this Malnutrition Awareness Week, I'll come back to that in just a moment, a very important way of promoting these informations, and the ONCA conference that we're attending right now. But on top of that, we always continuously also put on the website ways of sharing successes, good practices. What worked for me may work for somebody else. So I'll tell the story of how we did it. And I think there's a lot to pick up online as well. So this is how those circles work within the European Nutrition for Health Alliance. And I must say that I'm extremely grateful for all the participation that we have from all of the groups that are involved at different levels and all the national bodies that are out there, the national ONCA teams, to make it possible to have this EU4Nutrition session today and the meeting and the projects that we're running. So just a word about the Malnutrition Awareness Week. This is something where we've teamed up very strongly now with ESPEN. ESPEN has, of course, the scientific background that we need in order to promote things. And then we are working with an online program that ESPEN is presenting with the data, the information. Lots of really good stuff is coming out from them. But we also work individually with the different countries. And you can see all the countries that are going to be involved. And this will take place in November for the ESPEN online thing, and many countries will run it during that time. But because of differences in different countries, we are always flexible with the timing, so it may not be exactly those dates for your country. But anyway, this is an important event that's coming up as well. So let me just round up before I hand over to my co-moderators to give their word of welcome as well, with 7 key EU4Nutrition initiatives that we're running right now. And that slide was apparently gone. So, well, there's always something. But we will be back with that a little bit later. So it's like they say on the news channels, coming up next, right, to keep you interested. Okay, so I'll just hand over to Fanny. So please, the floor is yours.
Thank you very much for the introduction. Dear distinguished guests, colleagues and friends, it's a great pleasure to be here with you today. The ONCA conference stands as one of the most important initiatives in Europe, bringing together experts, policymakers, patient representatives and healthcare professionals to advance the mission of achieving optimal nutrition care for all. It is both a joy and honor for the Hellenic Dietetic Association to co-organize this important event together with the Hellenic Society of Medical Clinical Nutrition and Metabolism, under the auspices of ONCA campaign. Since 2020, Greece has proudly been the 19th member of the ONCA network, actively contributing to the collective effort to ensure that every individual who can benefit from nutritional care has the opportunity to receive it. In this spirit, we are proud to announce that a major milestone has recently achieved in Greece. By law, a new public law entity for dietitians nutritionists has been established. This body will serve as the official voice in dialogue with the government, ministries, patient organizations, and other stakeholders, with a mission to strengthen access to nutritional care and eliminate inequalities. Equally important, in 2024, Greece took a decisive step forward by enacting legislation that mandates the systematic screening for nutritional risk in all hospitals. This landmark achievement marks a turning point in the integration of nutrition into clinical care pathways and reinforces our shared belief that nutrition screening is a critical first step toward a timely and effective nutritional care. These developments highlights more than ever the vital role of dietitians in healthcare systems as advocates, experts, and leaders in delivering optimal nutrition care to all who need it. Our commitment is unwavering. Through collaboration, scientific excellence, and innovation, we can build a future where nutrition is recognized not as a privilege, but as a fundamental right for every individual. We are truly honored to host you all here and look forward to a conference filled with fruitful discussions, partnerships, and inspiration. Thank you for being here. Welcome to Athens. Welcome to ONCA 2025.
And last but not least, it's a great honor and privilege to have you all here. Guten Morgen, buongiorno, buonasera, guten Tag. It's bonjour. It's an excitement for all of us who have started this journey back in 2010, establishing the Graceman Society, that we have all these big heads around us, all the big brains of ESPEN and of ONCA, and all of you from the, let's say, European nutrition family around. It goes without saying that we couldn't have made it without you, and I don't mean just the organization of this event, but also this whole journey which brought us to having our 8th Congress a couple of weeks ago, hosting for the second time the Adriatic Club of Clinical Nutrition, having hosted already the European course of clinical nutrition, as Rocco knows and has appointed it to us a few years ago. But as Ole also said, it's very important that we have been using your help and you have been using our initiatives in a good way, and this is how we have been establishing 2 courses of medical nutrition at the Medical School of Thessaloniki, and actually at 12 o'clock today I was supposed to teach in Thessaloniki, and they are going to miss it because of you, Ole. But I'm going to do it next week. And with all this in mind, I'm very excited to hear what is going to be interacted within today and tomorrow, bringing all the good practices in place. And this is how we have been able to follow 3 different steps in the last almost 10 years in the Greek legislation, starting from establishing nutritional support teams, making a step forward to making clinical nutrition departments at hospital, making another step into promoting nutritional screening, and making the last step last year, making nutritional screening obligatory in the cost of not getting reimbursement. This is the only way to actually make it happen in Greece. And I'm very much hoping that we are going to further learn from your good practices, and maybe you will learn from some of our not too bad practices, and in that way we're all going to end up wiser. Thank you so much for being around and for taking the time to give your knowledge to us. So, everybody thinks the Greeks are lazy and delayed, but we're not. And you see, we're already 6 minutes ahead of the schedule. May I continue with the next step, Ole? So, with no further delay, we're going to initiate the first session, the holistic perspective on health and integrated nutritional care. The first speaker is going to be Maria Panoussopoulou, and I will kindly invite you to come here. She's an HR and administrative manager in the National Security agency EOP. She's the Vice President of the Institute of Health and Technology Promotion. And I would, in advance, kindly ask Grigoris Rizvas to be patient, because once the minister arrives, he's going to be speaking before you.
He's the minister.
I didn't vote for him. But he helped us with the legislation.
Okay. Good morning. It's nice being here with you. I would like to thank the organizing committee for this invitation, and I think that's a very great job to have you here in Athens, because there are steps to be done, and we are looking forward to it. So, my presence here is to talk to you about the economic case for reimbursement of dietetic care in Greece. So, since 2012, in the Greek healthcare system, the National Organization for the Provision of Healthcare Services, named EOP, is the one and major organization that provides health services to beneficiaries. EOP has to purchase health services for insured persons, pensioners, and the protected members of their families. We have to establish rules on design, quality, development, evaluation, safety, efficiency of the health services market, to manage and control funding and make rational use of available resources. Also, we have to do the definition of contractual criteria and conditions for the procurement of health services with public and private sector bodies and contracting physicians. Finally, we have to negotiate with all contractors and their remunerations, the terms of their agency's contracts, and the prices of medical devices, medicines, and of course FSMPs. So let me show you the AOP in numbers. We have 105 service points. We have 1,600 of employees. We had 37,000 providers for 11 million people, and we have to deal with an annual budget of 7.5 billion. So we all know that nutrition plays a crucial role in the maintaining of overall health and well-being. However, for people with specific medical conditions or nutritional needs, standard diets may not be sufficient. This is where food for special medical purposes come into play, which are intended for the dietary management of various medical conditions. AOP, as the major national healthcare provider, reimburses FSMPs following good practices and ensuring the maintenance of patients' health. So let me show you the diseases that we reimburse. First of all, inherited metabolic diseases, celiac disease, malabsorption for certain causes, fistulis gastric, gastroduodenal and ileocolic, cystic fibrosis, feeding through gastrostomy and jejunostomy, nasogastric feeding for children, food for children with cow's milk allergy or eosinophilic gastroenteritis, premature and underweight infants and infants with necrotizing enterocolitis or short bowel syndrome, and finally children with solid organ transplantation with renal failure or liver failure. So what was the situation before AOP? By 2016, the total expenditure of FSMP's reimbursement was more than 45 million euros. The procedure of FSMP's prescription was not digital. Causes of fraud prescriptions were revealed. Patients gave out of pocket money and then paid off by AOP after 2 or 3 months. And there was a great need for expenditure reductions. All of the above, all these reasons, created a situation where policy decisions were necessary. So, in order to make decisions and create reimbursement policy, there must be data. AOP had data, but that data were in paper and not in a centralized and organized manner. But we need more from that. We had to know the number of patients receiving FSMPs. We had to know the number of patients per ICD, We had to know the number of FSMPs for each ICD. We have to know the FSMPs in the whole Greece that were and the providers, and also the FSMPs that were reimbursed. And also we had to know who doctors prescribed what. So the AOP, Registry and Reimbursed Medical Device and FSMPs Registry, which is a sophisticated digital tool, was designed and implemented by late 2016 or early 2017. That was founded by law. So the registry is a tool that helps us to have an end-to-end traceability, to have price monitoring and policy enforcement. It helps us to product evaluation and medical effectiveness, to give us a medical effectiveness feedback. Which is a process. In order for a product to be reimbursed, its manufacturer or importer or distributor in Greece should make an application through the registry. AOP, after the assessment of the product, sets the reimbursement price, and then the provider, which can be either the manufacturer or the importer or the distributor, should have a contract with the AOP. With the implementation of the registry and the contracts with the providers, the expenditure boundaries of the FSMP's reimbursement were set into global budget. The use of global budgeting serves to control the expenditures. Behind them is the mechanisms of rebate and clawback, which help the expenditure containment into boundaries. So I will show you two pictures and show you the true situation. This is the way that the expenditure of FSMP's reimbursement was from 2014 to 2018. We see 2016 was the big line, whereas the decline came in 2017 and 2018. But is that all the money that the OP reimbursed? No. The true picture is here. We see 2016, the expenditure was more than 40 millions and a little bit less than 45, but 2017 and 2018, AOP in reality paid only 20 million euros. What happened to the rest money? These were taken back from the providers through the mechanism of rebate and clawbacks. So, although the use of global budget and the mechanisms of rebate and clawback helped AOP to hold the expenditure, another problem arose. The providers were burdened with very high percentages of haircuts. So AOP had to plan new policies to overcome the situation. But at that point, a lot of data was available to help us toward the right decisions. We had the data from registry, we know the true expenditure, we have number in patients, and we had the diseases, and all of that was electronically in our big database. So what we did from 2019 to 2022. First of all, we set the monthly reimbursed amount of each product, so what we call volume ceilings. And that was according to the ICD. Then we have to connect each FSMP to ICDs. Then we had to connect each ICD to the doctor specialization. We had to set price per energy or per protein content to specific registry categories, and these categories were the ones that had a very big expenditure. Then we split the budget for adult and children, FSMPs. And after that, we had to do virtual barcodes and finally the real-time approval of the prescriptions. And all of this was in a digital manner. So this is a picture of how we did the volume ceilings for ICDs for children. We see the ICD on the left. We see the age of the children and the number of pieces allowed. The same thing for the adults, the ICD and the number of per monthly pieces of food. We had to do the pricing. We set the price for each kilocal or each protein grammar in each food. So we have the same way to reimburse products. We set the real-time approval in order to simplify the process of the approval without bureaucracy, to protect the reimbursement against fraud, to collect data in a personalized manner, so to develop statistical indicators in order to support decision-making at the organization level. And in summary, all this digital transformation for the FSMP's reimbursement had to do with the registry products, the ICDs, the reference pricing, the e-prescription system, the closed budget, the virtual barcodes, the volume ceilings, and the real-time approval. All of this, with all of these tools, we had a better expenditure control, we enhanced access to healthcare data, and we improved quality of projects and services. But we have more work to do. We have to leverage healthcare data to identify patients' unmet needs. We should reevaluate the list of reimbursed diseases. We have to reevaluate the list of reimbursed FSMPs and set criteria. We have to give access to quality nutritional care. We have to reevaluate the global budget, to expand patients' registry across the new therapeutic areas. We have to negotiate the reimbursements of FSMPs. We have to promote education about the dietary care and the need to reimburse FSMPs, and all of this in order to provide improved patient care and centered services. So, thank you very much for your attention.
Thank you very much, Mrs. Panosopoulo. We'll have a discussion later, so we can have the questions later.
Okay, thank you.
Thank you. Now we can go to the next presentation from Mr. Grigoris Rizvas, Vice President of the European Federation of the Association of Dietitians, EFAD. He will talk to us about the joint approach to nutrition care in Europe 1. Mr. Rizvas, the floor is yours.
Thank you, thanks a lot. I must change my glasses. Yeah, I'm getting older. Okay. First of all, thank you all for being here in Athens, and thanks to the organizers for inviting us. Our president, Annaminge Van Hinkel, was supposed to be here, but she couldn't due to illness. So I volunteered to talk on her behalf, since I live just 10 minutes away from here. So IFAD is the voice of European dietetics. We aim to, our primary goal is to improve nutritional health and promote sustainable diets. And our main aim is to, our vision, let's say, is to see a Europe where every citizen enjoys optimal nutritional health through universal access to evidence-based dietary care delivered by registered dietitians who are recognized as the leading authorities in nutrition. In collaboration with our members and stakeholders, as European Federation of Dietitians, we represent over 35,000 dietitians and 9,000 students across 30 countries in Europe. Our commitment as dietitians to strive appropriate nutritional care for all is clearly stated in the resolution we issued in 2023. You can see it here. We call it the IFAD Budapest resolution because we were there in Budapest. And this resolution emphasizes the importance of nutritional care as integrated part of policies and interventions to address critical and chronic health diseases. Guidelines should include relevant nutritional interventions, and it should be clear how nutritional care is implemented in the patient care pathway, from screening to diagnosis to treatment, with the aim to maintain, reduce risk to, or restore health, as well as alleviate discomfort in palliative care. A multidisciplinary approach, or even interdisciplinary approach, is important because there are many aspects which should be covered realizing appropriate nutritional care for patients. Dietitians, especially clinical dietitians, being part of these multidisciplinary teams, could take the responsibility for nutritional assessment with a holistic approach, the individual nutrition and dietary counseling, and being the coordinator, contact, and source of information regarding nutrition. Our IFAD resolution on safe and appropriate nutritional care for European citizens perfectly fits with the Manifesto for Health Equality in Europe from ENHA, which also reflects the importance of integrated care and multi-stakeholder approach, both on policy level as in daily health care, to impact patients' health. IFAD is therefore a proud partner of ENHA and is happy to collaborate with various stakeholders. This manifesto is an example of launching and coordinating a parliamentary interest group on nutrition within the European Parliament policy to ensure nutrition in all policies through policy debate and cross-committee collaboration. Other activities are policy papers, briefings, events, policy roundtables, and support for nutrition-related amendments in relevant EU legislation. One of the activities we paid attention to, together with ENHA, is the Malnutrition Awareness Week. European Malnutrition Awareness Week is an annual campaign to raise awareness of disease-related malnutrition and its impact on healthcare systems, recovery, and quality of life. Activities are pan-European campaigns, national activations, media partnerships, and EU-wide policy stakeholder outreach, with a goal to position malnutrition as a public health issue that deserves systemic attention across policies. We inform our members about it and encourage them to post in social media and all other media ways of communicating to the public, and we made several posts during the Malnutrition Awareness Week. Our dietetic network on oncology also translated into concrete key messages showing the essential role of nutrition among cancer patients. As said, collaboration with stakeholders and other healthcare professionals is important for us. ESPEN, EASO, EFPC are examples of some of our important collaborating partners. Also, our position as a non-state actor in WHO Europe is essential and allows us to work together with WHO and other partners on important nutritional issues. And I'm getting to the last part of my presentation. I want to showcase briefly some examples we are currently working on. You can see this one in April. We have a fact sheet that was launched on sarcopenic obesity. This is the first step in creating awareness of this critical but overlooked health issue. More activities will follow to help governments and healthcare professionals to address this complex condition effectively. You can think of the appropriate screening, monitoring, and management of obesity in the presence of sarcopenia, including muscle function, physical fitness, and body composition changes being relevant goals in clinical care. Also, ESPEN provides valuable evidence-based recommendations for clinical nutrition, as we all know. An addendum specifically tailored for dietitians may help to bridge the gap between these established guidelines and routine clinical dietetic practice. Such addition may enhance the accessibility, clinical applicability, and relevance of the guidelines for dietitians in their everyday practice. IFAD has recently conducted a survey about the needs for such an addendum, and we hope to present the outcomes at the ESPEN Congress. Following this, we will develop this addendum, and besides such addendum, IFAD proposes experienced dietitians who participate in the development and revision of ESPEN guidelines. The last example I briefly want to address is the collaborative work on enhancing nutritional care in primary health systems. Primary care is well positioned to address malnutrition and food insecurity through early detection and timely intervention or referral. Leveraging this potential can yield significant health benefits and reduce social and health inequalities. Nutrition competent teams, including dietitians, are essential but often absent. Their integration into primary care can bridge the gap and bridge service gaps and enhance care quality. Dietitians are uniquely qualified to deliver person-centered, evidence-based nutritional care. They ensure diet quality and food security across the lifespan, and they support and educate other health professionals. Our policy recommendations for primary care, but it also applies to all healthcare systems, are 3, integrate dietitians into all primary care teams, provide nutrition training for primary care staff, and prioritize screening for malnutrition and food insecurity. And with this, I want to close my presentation. The minister hasn't come yet. Yeah, okay.
It's okay. Thank you very much.
Thank you. Thanks a lot.
Thank you very much for your insightful presentation. The question will come later also. As we can see, we can all understand why ONCA campaign is truly important across Europe and Greece, of course. It is estimated that 39 million people worldwide are at high risk of malnutrition. Moreover, let me see the numbers. Recent epidemiological data from the World Health Organization indicates that malnutrition affects 30 to 50% of hospitalized patients, 40% of cancer patients, 30 to 70% of older adults, and 38 to 78% of critically ill patients in intensive care units. This shows how important is all this act. Thank you very much. We're now proceeding to the next topic. We will now begin by giving the floor to Mrs. Vasiliki Vakfoutsi, I apologize for this, who will speak to us on the topic of a holistic approach on nutritional care and quality of life. Is Mrs. Vakfoutsi here? I'm sorry.
Hello, everyone.
Thank you very much.
Yeah, hope you hear me and seeing my presentation. And thank you for the invitation at today's conference to speak in such an important topic. I'm not only here to represent the umbrella organization, but also I became from a therapeutic category that has a very close connection with nutrition. I became the IBD, the inflammatory bowel disease therapeutic category, and I also work for an organization about IBD, so I'm really keen on nutrition, and also recently participated at the new ECHO guidelines about nutrition and diet for IBD patients. So I'm here to share you the patient perspective on this topic, and I'm beginning that. First of all, why it matters to patients? Because nutrition is not only food; it's more than that. Is the heart of recovery, of management, and of course it gives quality of life for patients. Chronic illness, not only those who has a connection with IBD, with nutrition, but all chronic illnesses often bring some dietary restrictions and of course, fortunately, some deficiencies. the relational well-being is often overlooked in care models because you think that in hospitals the situation is not ideal for take care of the patient as a holistic approach. And of course, if we have pure nutrition, we have also pure outcomes with disease flare-ups, hospitalization, etc. The quality of life, the nutrition impact on quality of life. Malnutrition and some restrictive diets affect the physical energy and the strength of a patient, the mental health of the patient, and unfortunately the social life and daily functioning. And this is very important, especially when we speak about young people living with chronic illnesses. And of course, don't use the stigma of eating differently or not being able to eat normal foods. And quality of life is not just surviving, it's living well. We have to think about it, we have to have it in mind when we speak about the quality of life. Which is the gaps in current nutritional care? Unfortunately, nutritional care is often fragmented or reactive, especially in public health care systems, is not personalized and is lacking of psychological support. And in some cases, even those days, dietitians may not be part of the care team in every healthcare setting, and I think that this is very, very important. We have made some steps, and new legislation also make some steps, but we have to make better solution for this. And I came to what patients want from the nutrition. Patients want access to dietitians trained in our health condition, not only a dietitian, but an experienced dietitian in our health condition. We need emotional support because it's not easy to have restrictions in your diet. We need practical and real life solutions. Just think that if somebody has a very, very busy everyday life, we have to focus on this and make a personal practical diet plan for this person. And we need also education and resources about our disease and the nutrition. We want to be partners, not passive recipients, of course, and that is not only for nutrition, but in every healthcare aspect. A holistic nutritional care includes both the clinical nutrition, but also the personal goals for every person that receives the nutritional care. And to achieve it, we have to make an interdisciplinary care model with ideally a dietitian, a physician, a psychologist, a social worker, and the patient has equal voice in the interdisciplinary team. But is about treating person just the disease, which is to better care with pathways and guidelines,
apologize for the
and also to ensure equity in nutritional trials.
We can hear you very well. Now we have a problem with the connection.
I think I had a connection issue.
Now we can hear you.
Okay,
Again.
sorry about it. And I continue from the same part, and I continue with the empowering patients through education and support, which is a main goal for patient organization. We teach patients how to make informed food choices based on their condition, and we help patients understand the relationship between diet and disease progression, and offer workshops, resources, and access to support networks for patients. And I close with a call to action for everyone. for healthcare professionals involve us early and listen to our lived experience, and also integrate dietitians into every care plan. That's for physicians mainly. For policymakers, reimburse dietetic care and support funding for nutrition-related research. For industry and researchers, include quality of life and nutrition in metrics. And for us, for patients, take an active role in learning and managing your nutrition. And some final thoughts before closing this presentation. Nutrition is a right, not a privilege for someone. Nutrition is key to manage chronic illness and maintain a good quality of life. Holistic care improves health outcomes, emotional well-being, and dignity of a person. And of course, we deserve holistic care that nourishes both body and soul.
Listen,
And a holistic
can
approach
we ask you to
empowers
share the
patients.
slides? Could you just show the slides? Is that possible? You can try that again. Maybe that blew it completely.
Let me fix it. The technology is not with us. Do you see the
Perfect,
slides
perfect.
now?
Thank you very much. Great, thank you.
Yeah. Some final thoughts that already said, and I'm closing with that a holistic approach empowers patients to live fully, and that's the main goal for everyone, for healthcare professionals, for dietetics, for patient organization, and also for healthcare policies. And with this, I will thank you again for the invitation, and I'm here to make a panel discussion after this presentation. Thank you.
Thank you very much. We were ready to ask you to stay for the panel discussion, but you're aware of it and you will stay with us. I would like to make a comment and tell you that dietitians also want to be partners of the patients. And it's very important to hear that you really appreciate the dietitian's work. And we want to be together, and we hope this could be easy for everyone. Not the dietetic care not to be a privilege, but a human right. Thank you very much for that. Now.
Yeah, we're waiting for the minister. He is very close by. Michael has gone out to meet him. So I just suggest, since we've been sitting now for 1 hour, maybe we could just take the opportunity to stand up, maybe talk to your neighbor, and we'll be... Please don't leave the room.
For your patience during this short break, but mostly we thank the minister who stopped all the activities he was undertaking just to come here for us. Thank you, Mr. Minister of Health. I have already let them know that despite the fact that I did not vote for you, not yet, if ever. You helped us with the legislation last year, and we are thankful for that. And with no further delay, I would kindly ask you to talk about the Greek ambitions in health innovations and the role of nutrition and care, also given the very recent legislation that was voted last week at the Parliament. Thank you for being with us. The Minister will be talking in Greek, and every few minutes I will be translating the main points, only if I agree with those.
First of all, I want to thank everybody from abroad here in Athens to this conference and to the university. It's a university I love the most because I graduated from this university 30 years ago. For official reasons, I will address in the Greek language. You will permit me that. But I want to make you feel very welcome to our country, and we're very honored receiving you here and for me participating to this event. So thank you very much for being here. Λοιπόν, καταρχάς να ευχαριστώ τον κύριο Χουρδάκη για την πρόσκληση και όλους τους οργανωτές. Η αλήθεια είναι ότι έχω μια φοβερά δύσκολη μέρα. Έχω φύγει με τη μηχανή σκαστός, πρέπει να γυρίσω γρήγορα πίσω, με περιμένω και μια 50 ξυλογραφία αυτή τη στιγμή. Ήθελα όμως να έρθω για τους εξής λόγους. Είμαστε μια χώρα που κανονικά λόγω της μεσογειακής διατροφής θα περίμενε κάποιος θα είχαμε πάρα πολλούς δείκτες καλούς υγείας, στη διατροφή μας, στο βάρος μας, σε όλα πηγαίναμε περίφημα. Αυτό θα ήταν το ιδανικό, αλλά δεν είναι καθόλου αυτό που πραγματικά συμβαίνει. Είμαστε δυστυχώς μια χώρα που διατρεφόμαστε γενικώς πολύ άσχημα, έχουμε τεράστιο ποσοστό παχυσαρκίας, από τις πρώτες χώρες στην Ευρώπη. Είμαστε πρώτοι στην παιδική παχυσαρκία. Έχουμε τεράστιο αριθμό διαβητικών και υπερτασικών που κυρίως προέρχεται αυτό από το βάρος και από την διατροφή που είναι πολύ κακή. Άρα δυστυχώς αυτό το θέμα δεν έχουμε καταφέρει να κάνουμε αυτό που πρέπει να κάνουμε. Όταν έγινε Υπουργός Υγείας για αυτή τη δεύτερη μου θητεία, λοιπόν, είπα πρέπει να ασχοληθούμε σοβαρά με αυτό και για λόγους επί της ουσίας να ωφελούμε κάποιους ανθρώπους να μπουν ποσοστά από τα παιδικά τους χρόνια στο να μάθουν πώς να διατρέφονται σωστά, γιατί αν μάθεις από μικρός, αυτός ακολουθεί μια ολόκληρη ζωή, αλλά και το πώς θα μπορούμε να αντιμετωπίσουμε τα εγγενή προβλήματα που έχουμε, που τελικά επιστρέφουν σε χειρότερη ποιότητα ζωής, σε περισσότερες ασθένειες, σε μεγαλύτερη πίεση στο σύστημα υγείας και το καθεξής. Ναι.
So, I can also guarantee, as he said, he came with a motorbike because the day is very hectic. There are at least 50 people waiting for him.
Always with a helmet.
Of course, and the helmet. So, despite the fact that we are a country advocating for the Mediterranean diet, and one would be expecting that we have all the positive indices in terms of health, this is far from ideal. And there is very bad nutrition and nutritional habits among the Greek population, leading us to be among the first in adult obesity and the first in childhood obesity. All this leading to also to diabetes mellitus, but also to hypertension. And because it's very important to give a specific interest in health and in good habits, this is why it should start early enough. So during his second term as the Minister of Health, he said we should do something, and it was about that he was explaining what.
Λοιπόν, έχουμε ξεκινήσει μια σειρά πολιτικών. Ίσως είναι η πρώτη φορά, νομίζω, που η πολιτική ηγεσία του Υπουργείου Υγείας ασχολείται τόσο σοβαρά με αυτό το θέμα. Πρώτον, εντάξαμε στο Ταμείο Ανάκαμψης 2 μεγάλα έργα. Το ένα για αντιμετώπιση της παχυσαρκίας των ενηλίκων, το οποίο αυτή τη στιγμή εφαρμόζεται σε συνεργασία με τον Παγκόσμιο Οργανισμό Υγείας, και το άλλο για την αντιμετώπιση της παιδικής παχυσαρκίας, το οποίο υλοποιείται σε συνεργασία με την UNICEF. Κύριε Χουρδάκη.
They have introduced a series of policies, among the most important that two main two main projects are being done, which are also part of the recovery and resilience facility. I'm adding 37 billion for Greece. And one is the program against obesity in close collaboration with the WHO and also the WHO office that is being in Athens, but also a program for childhood obesity in collaboration with UNICEF.
Yes. Το δεύτερο που κάναμε, και η αλήθεια του αυτό έπαιξε ρόλο ο κ. Χουρδάκης, εμένα για την εφαρμογή πολιτικών που πιστεύω τα πολιτικά και τα κομματικά δεν με νοιάζουν καθόλου. Εάν κάποια ιδέα είναι σωστή, δεν την εφαρμόζω. Ο κ. Χουρδάκης, η αλήθεια ήρθε και με ενημέρωσε για αυτό να θεσπίσουμε κανόνες διατροφικής παρακολούθησης μέσα στα νοσοκομεία, ώστε να έχουμε μια στάνταρ διαδικασία όπου θα μπορούμε να παρακολουθούμε τι πραγματικά δίνουμε στον ασθενή και αν αυτό που του δίνουμε είναι ταιριαστό για αυτόν. Αυτό το κάναμε, ακόμα στο διάστημα τότε της εφαρμογής. Πρέπει να σας πω εδώ ότι μέσα στο 2025 θα κάνουμε τη μεγαλύτερη προκήρυξη για την πρόσληψη διατροφολόγων στα δημόσια νοσοκομεία που έχουμε κάνει ποτέ στην ιστορία.
Also, and I would like to underline or highlight the help that I got from me. In the case that he came and explained to me why it should be important to be screening and focusing on what the patient is truly getting at the hospital setting, and for what it's up to me, I don't care about parties or ideologies as far as this is good for the state or for the patient. And this is why we made all these standard procedures that are in the new legislation, and we're at the phase of implementing them. And you said also...
Και είπα θα κάνουμε τη μεγαλύτερη προκήρυξη.
And in the next, during this year, it's going to be the biggest announcing or hiring procedure for new staff of dietitians in Greece.
Θέλουμε στην προσπάθειά μας να δώσουμε το σήμα ότι η πολιτεία αντιλαμβάνεται πάρα πολύ σοβαρά και το Υπουργείο Υγείας ότι οι διατροφικές μας συνήθειες δεν είναι μία πολυτέλεια, αλλά αποτελούν στοιχείο του πυρήνα της καλής υγείας και της ποιότητας ζωής. Προχωρήσαμε μόλις την περασμένη Πέμπτη στην ψήφιση στη Βουλή της ίδρυσης του νομικού προσώπου δημοσίου δικαίου για την Ένωση Διατροφολόγων Διαιτολόγων Ελλάδος, με σκοπό να ξεκαθαρίσουμε ποιος μπορεί να κάνει αυτή τη δουλειά, τι προσόντα πρέπει να έχει, πώς παίρνει την άδεια ασκήσεως επαγγέλματος, ποιες είναι οι ποινές για την αντιποίηση αυτού του επαγγέλματος, κυρίως διότι είχαμε διαπιστώσει ότι έξω πάρα πολλοί υποδίονταν τους διατροφολόγους χωρίς να έχουν όμως την κατάλληλη επιστημονική γνώση.
And in addition to all these practices that we are doing in securing better health and better nutrition for Greeks, last Thursday, I think Thursday or Wednesday?
Wednesday. Thursday was 1st of May.
Last Wednesday, we did a new legislation for a new legal person governed by public law for dietitians and who is allowed to be conducting dietetic practices because there were a lot of people mimicking them without having the needed education.
Ο κυριότερο λόγος που το κάναμε είναι γιατί θέλουμε να διασφαλίσουμε ότι αυτοί οι οποίοι πρόκειται να δίνουν συμβουλές διατροφικές και δίαιτας στους συμπολίτες μας δεν θα είναι κάποιοι που διαβάσανε κάτι στο διαδίκτυο ή που κάνανε ένα σεμινάριο 5 μηνών, αλλά είναι κάποιοι που αυτό το έχουν κάνει πραγματικά σκοπό ζωής, έχουν αφιερώσει κόπο και χρόνο για να το μάθουν και άρα οι συμβουλές που θα δώσουν έχουν πραγματική επιστημονική αξία και δεν είναι απλώς για να χάνουμε χρόνο.
In our core for this legislation was our worries that those that should be counseling people for the diet and nutrition interest should be people with who have invested time and effort in getting properly educated and not some people that got the information over the internet or after a 5-month seminar or whatever.
Πιστεύω ότι σε διάστημα 1,5 έτους τόσες πολλές συντονισμένες ενέργειες για την διατροφή και την πραγματική της αξία στην παροχή υπηρεσιών υγείας και ποιότητας υγείας στην πατρίδα μας δεν έχει ξαναγίνει. Έχουμε πολύ όγκους να δουλέψουμε μαζί σας. Θέλω να συγχαρώ για την σημερινή διοργάνωση. Είναι σημαντικό για μας ότι και άνθρωποι από το εξωτερικό επιλέγουν την Αθήνα για να κάνουν ένα τέτοιου τύπου γεγονός. Και να πω για άλλη μια φορά, και νομίζω ότι το βλέπετε στην πράξη όχι στα λόγια, ότι είμαι απολύτως πρόθυμος να ακούσω τις συμβουλές σας. Διότι, θέλω να είμαι ειλικρινής, εγώ δεν είμαι ειδικός σε αυτά και μου αρέσει να ακούω τους ειδικούς, δηλαδή εσάς. Εάν έχετε επιπλέον ιδέες που πιστεύετε πρέπει να εφαρμόσουμε, να μην διστάσετε να μας τις πείτε. Πρέπει, και σε αυτό το Υπουργείο Υγείας είναι το κατεξοχήν Υπουργείο, πρέπει να παίξει ρόλο, να στείλουμε ένα σήμα στον ελληνικό πληθυσμό ότι κάτι που είχε γράψει ο Ιπποκράτης πριν από χιλιάδες χρόνια σε αυτήν τη χώρα, ότι το φαγητό σου πρέπει να γίνει το φάρμακό σου, αυτή είναι η ρίση του Ιπποκράτους. Λοιπόν, αυτό πρέπει να το κάνουμε κανόνα ζωής, γιατί μόνο έτσι, αλλάζοντας καθημερινές μας διατροφικές συνήθειες, θα αλλάξουμε πραγματικά την ποιότητα ζωής στον ευρύτερο πληθυσμό. Δεν θα είναι εύκολο, γιατί να αντιμετωπίσουμε πια κακές συνήθειες κάποιων δεκαετιών. Τώρα το λέω και από τους Έλληνες εδώ, που κυρίως πάμε στο γύρο, στο έτοιμο φαγητό, στα κατεργασμένα και επεξεργασμένα τρόφιμα, τα οποία μας κατακλείζουν σχεδόν παντού. Εγώ τρώω από όλα αυτά, μην παρεξηγηθώ. Δεν το λέω ρατσιστικά, αλλά πραγματικά τρώω πια όσο είναι λιγότερο, γιατί αντιλαμβάνομαι ότι με βλάπτουν. Άρα λοιπόν, αυτό πρέπει με κάποιο τρόπο το στείλουμε ως σήμα στην ελληνική κοινωνία, συγκροτημένα και σοβαρά, για να δρέψουμε σε λίγα χρόνια τους καρπούς μιας καλύτερης ποιότητας ζωής.
So, you should be able to understand that during what has happened in this 1.5 year, all this concentrated or coordinated effort towards a better health is something new for the Greek standards. We thank you for being here in Greece, and it's always good that we have people from abroad choosing Greece and Athens for such events, and we are keen to be working with you, open to new ideas, and this is something that we have shown in real practice and not just futile words, that whichever good idea might come out from this event, please come and share it with me. I'm here to listen to that because I'm not a specialist in this field, but I'm open to hear and learn from you. And moreover, we'd like to also send the signal to the Greek population. And as Hippocrates had said a few thousand years ago, that let food be your medicine, we should incorporate that for future generations and slowly make us the epicenter, better nutritional habits instead of processed foods or gyros or whatever, which, by the way, I'm eating and I'm receiving. But I know it's not always good for my health, and I'm trying to reduce it as much as possible.
So, thank you very much. Again, you are very welcome. You will permit me to leave SAP. I have to go back to my office. But I wanted to be here to send a very clear signal that what you are doing here today for us is important. So, thank you very much.
And, κύριε Υπουργέ, μία ερώτηση ίσως, μία ή δύο ερωτήσεις.
Ναι.
He will be so kind, aren't you, to stay for maybe a maximum of 2 questions. So, feel free to ask. Ole. Ole ήταν ο πρόεδρος της ΕΣΟ παλιότερα και είναι τώρα πολύ...
Ωραία.
Well, Mr. Minister, it's a true pleasure to have you here. We are very grateful for your presence, and it's a unique opportunity. So, from your point of view, what is the smartest thing we can do in other countries to get to approach people like you in your position? Because this is one of the hardest things that we're facing.
Approaching me is a very easy procedure. I'm very open. When I think something is under my job prescription, I want to do it. And I take the responsibility as Minister of Health that changing the way we use food, it's a health top priority issue. It's not just a luxury thing. It's top priority, and you see where we stand today. Health budgets are in a very big pressure. New drugs are being invented day by day, which is marvelous for humankind, but big challenging for the budgets. So we have to find ways to survive. In order to do that, we have to be much more efficient in πώς είναι η πρόληψη στα αγγλικά? In prevention. Changing our food habits, maybe food habits and the way we exercise ourselves every day, it's the two things that would really work for prevention. Because if we control our food and if we exercise ourselves 2 or 3 times per week, then prevention will be there. Prevention is not the diagnostic we will do. The diagnostic will help to find something easier and fix it as fast as possible. But in order not to have the problem in our health, we have to follow these two simple everyday habits.
If somebody is not as open as you, the other Minister of Health, as you meet them in the Minister Summits, what is the way to approach them?
I think using organization, for example, as WHO, that would explain the effect of this kind of advices to the budget would open doors. Because this kind of challenge is challenges of all the ministers in European Union. And it's the biggest fear all the ministers of health have for the future, because everybody understands that what is coming is very good and very bad at the same time. It's fantastic good that with AI and with quantum computing and with all these things we can do trials much faster and we can find more molecules much faster than we did before and cure diseases that we couldn't cure them before and give much more expenditure to our life expectancy and to everything. But all this creates the challenge of budget. So we have to change the way we work to be able, and this is not something for a country like Greece and for the budget we have. Even Germany and France cannot deal with the challenge in the future. So if you find a way to implement a big international organization and explain that this advice is not just for public relations, but at the end it will help us to solve this big, one huge problem all the Minister of Health now has to fix, I think doors will open. And maybe we could ask from European authorities or for some of the countries that will have the presidency in the years to come to put it in the health sector as a top priority, this kind of advices. Greece will be in some years the president of European Union. If I will be there, I will do it.
Super.
Thank you very much for coming and for sharing your thoughts with us.
Thank you.
We can stay here to go on with the next session. Give us 1 minute. I lost my notes.
Okay, we are going to ask the other 2 speakers who are in the room to please join us here. And
Mrs. We're calling Mrs. Panousopoulou, Mr. Grigoris Rizvas, and also Mrs. Vakouftsy is, I think, is here with us to proceed. Yes, to proceed with the panel discussion, the panel session.
I'm going to take Michali's place.
Just for a second.
yeah, we go ahead. Go ahead.
I think we can move on. Maybe, we have a question here. Please.
Yeah, I tried to start and I raised my voice. I would like to be in some way stimulated by what the minister said.
Hang on, we got a microphone for you. Okay.
He addressed the issue that he wants more prevention to contain healthcare costs. What would you think from the point of view of the dietetic world if we would consider certain interventions, not treatment, but prevention? And it might be that in chronic disease, addressing nutrition could be understood as a preventive measure because it's preventing occurring malnutrition. And this is a paradigm change because the financing of the healthcare system is only for treating conditions and not for preventing conditions. How can we, should we change this set of mind that the approach to nutrition as a supportive or preventing element could be important for the society? What do you think?
So I can be the first to try to answer. Well, first of all, we must all realize as health professionals that we must be talking more and more and focusing more and more on health and not illness. Most of us are trained as clinicians, so we must first of all look inside, our mind, culture, mentality, and try to work more interdisciplinary with other professionals, with decision makers, with people that are educating our youth, with people that are that have a role in setting up the cities of the future, taking initiatives on how we must be moving to go to work, or how much time we have as working people, how much free time we have to center more in ourselves and our family. So that has to do with our quality of life and our way of life. And dietitians as consultants, because we mainly, especially we're consulting patients and people without a disease, can have a key role on that, because I believe that there are, of course, other health professionals, but we are educated to help people change, modify their ways of life. So yes, of course, we should never forget the patient, and we should never forget secondary care and the people that are there in the hospitals, but we must work more in prevention, maybe through primary care, through the primary care environment as well. And what I would like to say to the minister, but he's not here, is, of course, we need a lot more dietitians in the hospitals, but we need, and we don't have, unfortunately, in Greece, this is a big gap in our health system. We don't have any or very, very few dietitians in primary care.
If I may, just a quick comment on that, actually. I think there are many instances in healthcare where if we prepare patients for certain treatments like surgery, oncology treatment, etc., we can be preventive, couldn't we? So maybe I think your idea is very good. Maybe we're focusing too much on when it's a bit too late or later, rather than pushing it from the beginning.
It should be on reimbursement. We should think what the reimbursement world is thinking about this concept.
Yeah. Is the sound on? No. Just a second. We'll get some button needs to be pushed.
Okay. Am I good?
Closer.
Declan O'Brien. Oh,
Yeah.
there we go. Declan O'Brien from the British Specialist Nutrition Association. I'm very, very interested in the Greek law, which mandates screening of patients coming into hospitals. So a couple of things. One, is it practically feasible? Because it takes a lot of resources. So can you tell us if it has been possible to actually screen every patient coming into the Greek hospitals in the past 12 months or into the future? But secondly, linking back to the very nice graphic you put up, Ole, in terms of the decision-making process, and also using the analogy, if you can stick with me, of eating an elephant. If you're asked to eat an elephant, it's very difficult to eat an elephant. It's so big. But if you chop it up into pieces, you can eat piece by piece. And I'm thinking, coming back to the piece, can we get European law, which is the same as your Greek law, which mandates screening in every country under law?
Well, first of all, we are working in NHAT towards creating a pressure group, let's say, in the European Parliament to start initializing legislation on nutrition issues, and of course, nutrition screening is on the top of this agenda. Well, now about screening in the Greek hospitals. Dr. Hourdakis, I think you can be much more helpful than I am in this. Have we managed to have screening of most patients in Greek hospitals, or what is the percentage today, or in the past year,
So the time is 12:24, so we have 4 or 5 more minutes for the discussion. But to respond, yes, but I don't want to respond. This is why. So no, the truth is this. You also heard the minister saying this year we're in the year of the implementation. Unfortunately, the percentage of screening hasn't actually is not higher after the legislation, because the legislation is not implemented yet. In Greece, from a legislation to the activation of it, you need one more paper to be signed. And this is what they are thinking at the moment. Πώς λέγεται αυτή? Εφαρμοστικός. It's like applicative signature or something like that. So we are before this step. This is why he said about implementation. But the problem is, even the directors of the hospital, the general managers of the hospital, they are not aware that they are not going to be reimbursed once this final approval is there. And when I'm meeting with them, with my parliamentary role, they don't believe me that the Chapter 70 of the legislation of last year is about reimbursement. No, that's too much. And when they see it, then you can see they are actually stressed, because they understand all of their patients' procedures throughout the last months is going to be ending to zero reimbursement. So I hope after the final step, this will change, and with the Greek Society of Clinical and Medical Nutrition and Metabolism, and maybe also with the help of the dietitians, we can do some research and seeing if the percentage is going to go up to 99%.
So if we have more concrete results, let's take the ones as a good example, the Greek paradigm, we can use these results in the pressure group we want to have in the European Parliament as IFAD and ENSPEN.
As far as I know, the risk management will be assessed in 24 hours after the entrance of the patient in the hospital. So we have some time to do that. It's not meant that when the patient comes in, has the risk assessment. We left a little time. There are also in the audience some dietitians who work in the healthcare system. Maybe they want to make a comment on this, about the appliance of the risk assessment management. Yes, Mrs. Amalia Tsangari. She's a dietitian in the, how do we call your hospital?
It's a
CAT.
CAT General Hospital. It's in one of Athens suburb. My question, I don't have a comment, I just have a question, is that currently when in our hospital we tried to, let's say, implement or make an effort in implementing this obligatory nutritional screening, that we understood that the system, ψηφιακό, the digital system, EPSME, which the capitals in Greek, was not ready for us. We were part of it, but we were raised as medical doctors, which is not, and I don't know how this can be fixed. Is it part of the new application law? This is my question for everyone. I don't know how, because it's an important step if we want an obligatory nutritional screening, so that dietitians that are according to law obligated to make an assessment, a nutritional assessment of the patient, how it will be incorporated in the digital file of the patient. So,
We
thank
still
you.
don't have an answer in this issue. I think also the government doesn't have one.
I actually would like to hear if Vasiliki could comment on the fact that what do patients here in Greece feel about the new laws and regulations? Is it working? Is it good? Are people happy with this?
It's not still in detail, so it's not working. Unfortunately, most of the patient follow-up by the public healthcare has no access to specific dietetic plans. There are only a few hospitals that provide this plan, but we see it very positively that is now being legislated, so maybe in the near future it will be a realistic plan for patients, and we need it because many of us need exclusive diet plans, and it's really good that the dietetics are made by dietitians and not by the physician or by someone who is here or by a nurse, which is the rule now for most of the public healthcare hospitals.
So can I just ask a question to the audience? I know that there are several people here who have been working with the same issues in other countries. If I could just have a raise of hands of those who have similar or almost the same legislation or have been pushing this. Is anybody? Yeah? Okay, so we have Portugal, Norway, Spain, Denmark. Yeah, okay, good. We have several countries. So we just heard the Greek minister say that he would be available to do a lot of things in this direction. So why don't you, all of you, go back to your ministers and say, we should gather all of you to have those ministers of health, when they go to the Europe next time, to join forces and push this. See, this is the strength that we can contribute with. So I urge all of you, and I'm sure Jost can help organize this so that we can make a push, and maybe next year we can see if we can push things all the way up to the EU for this all the way through. Please, we had the next issue here. Okay.
I'm Paweł Kabata. I'm a cancer surgeon from Poland.
Wait, let's see if she can get the microphone to work.
Thank you. I'm Paweł Kabata. I'm a cancer surgeon from Poland. So we've had the nutritional screening as obligatory part of the administration to the hospital for, I don't know, about 10 years. So it's obligatory. You have to do this the same way you do the physical examination. The other problem that we're facing is the quality of the assessment, because most commonly, because it's obligatory, most of the doctors don't really understand what it's really for. So the question that we always raise is, what's the quality of the assessment? Because I've seen severely malnourished esophageal cancer patients which were NRS 0, right? But as a comment to how to approach the parliament, So right now we have this situation in Polish Parliament that we have a parliamentary team for clinical nutrition, which is actually led by the one of the members of the parliament who is a clinical nutrition. He's an enteral nutrition patient with Crohn's disease, so he runs the whole team, and they really started pushing things forward. Like, for instance, legalizing the dietitian's profession as a medical profession, which has not been done for years. But the second thing they did is that they proposed additional mandatory screening for cancer patients, because we have something which is called the green card, which is like a fast diagnostic path for cancer patients. And one of the proposals, because right now it's being digitalized, and one of the proposals as the part of the digitalization is that each doctor, when putting all the numbers, checking all the tables in this digital card, will have to additionally check the tab which is, say, is the patient at nutritional risk. And this is actually the only thing the oncologist has to do, because if he clicks yes, the patient is a nutritional risk, then there is like another path towards the nutrition professionals, which will take care of the patient. Is this just this one thing they have to answer, yes or no? It's so easy. And then there are people who will take care of this. Thank you.
Yeah, please, Matthias.
Yeah, Ole, I just want to encourage you, or one of your comments you made before, that we should collect the, let's say, or maybe produce some kind of policy achievement map of Europe. So which country has achieved what by which methods or ways to approach politicians? Because I think this could be very helpful. If I, for instance, look what Anibal in Portugal did, or what you are now going to achieve here in Greece, then this could be also inspiring for us. And also our politicians sometimes ask, what about the other countries? And could we follow, and should we follow? So such kind of map, maybe not only regarding screening and nutrition management in hospitals, also about nutrition education in medical schools, so to see which country is where.
Yeah, that's absolutely, please.
I will try to answer this question. As the president of the Hellenic Dietetic Association, I was in a continuous conversation with the minister, and we were trying hard for these laws that you listened before. What we really did, what everybody should really do, is a very good lobbying. We need people around the ministries. We need people that know what to do. And I'm pretty sure that we need to talk with numbers, need to talk about the money. I wasn't really prepared, but we have from IFAD, we have the white paper. It's an analysis of the nutritional intervention and the cost effectiveness. There are some results from research, let's say, about the cost effectiveness. And 2 weeks before, I was in the parliament because I was representing the Hellenic Dietetic Association. And we talk about that the nutritional intervention and prevention can bring up to 1.9 billion euro as back to the society in 5 years. And also, according to research, to studies, for every €1 we invest to the nutrition intervention and counseling, the society takes back €63. They need numbers. They want numbers. They want to understand what they will earn from this for the new politics. And this is very important. And I think it's difficult to find studies about the cost effectiveness of the dietary intervention. And we should make more effort to have studies about the European cost effectiveness of the intervention, and also in every country. It's really, we call it, Almiro, it's really very, very cost, it costs. It's difficult to fund such a study, but I think it's a very important tool for us. This is, I think, what we should do. Thank you.
Yeah, money counts always. Elizabeth.
First,
Yeah.
this works.
Yeah.
Hello. Yes,
Yeah.
it does. First of all, congratulations to Greece for this important step
Speak
in
close.
better nutrition care for all. But as somebody else has touched upon, this discussion is very much about hospitals. But I'm sure, even in Greece and other countries, more and more frail persons stay in their own homes. And there we have the primary care as a very important strategic actor. So how about this screening program for the primary care and maybe even for elderly care? Because this is a great challenge around Europe, not at least with all those old people that we need to take care of.
Thank you, Elizabeth. As you know, I'm a family medicine doctor and have a strong interest in those primary care people. And last week I was at the Family Medicine Doctors Annual Congress together with two other members of the parliament who are also happening to be family medicine doctors, and we agreed that nutrition should be incorporated in their curriculum for the 5-year residency of family medicine. And I think if this happens, it will be the first step by increasing their awareness for this big portion of the population. And in parallel, we are also going to try to convince the Ministry of Health for the next step. But you know, and this is also maybe or could be a take-home message for other countries, if you go too fast, too soon, the minister would say no. So we started with what we regarded in the Gresham Society as the most important one, what is happening at the hospital setting, and the primary care setting is going to be the second one. And since you have asked what we can do by getting closer to the ministers of health, I think a very important part would be to get closer also to the people working in ministries of health. And now that we sat next to each other, we exchanged contact details, and she asked me for some help. I asked for some help, and we're going to work together, and maybe I can convince, not you in particular, but your department to also include primary care or whatever. So I think this is also a good step to go and persuade those close to those taking decisions.
Yeah, in fact, I wanted to ask Maria also, with the changes that you have been able to establish, my understanding, two key messages. One was you got rid of a lot of fraud, and you've been standardizing things a lot. So what is your advice when it comes to, because I would imagine that you are not the only country in Europe with this problem, and what is your main advice when it comes to dealing with fraud? We can start there.
Okay, thank you. That's a very nice question. Although we've done a lot of steps in order to avoid fraud.
Can you go a little closer?
Yes.
Yeah.
Although we try to make some big steps to avoid fraud, because we realized that there was a big amount of money spent fraud. No. Although always there be somewhere behind our head that something may be go wrong again. So the real-time approval was a very, very good tool that we made. And we tried to make the assessment of the products stricter. But there's not a certain way to avoid products that they are not very quality. They don't have a quality, or they are not appropriate. And that's a point where we need help. And maybe if we had a European frame, will guide us and know how what products to reimburse, the diseases that we reimburse everything for, because maybe one product is good for some person, but it's not very good for the other person. And we have to do with human beings and patients, and we want them healthy and strength.
Just
Strong.
a quick follow-up, and then we'll lead on. Because you were showing that the money was coming down, and there was some of that was fraud. Do you see a risk that you may be pushing too hard, and some patients are not getting what they need? That's a bit provocative.
Well, I'm not very sure about it, but we got rid of a lot of fraud prescription.
Yeah.
Although, as I told in my presentation, we need to reevaluate the budget and the needs of the patients. That's what I asked Professor here to help us in maybe reevaluate all these diseases and the categories. And of course, maybe a European guideline would be necessary. Also, fraud and cost and sustainable systems. For me, I have 3 letters in my mind. HTA, nutrition, and foods for medical diseases, for medical purposes, they have technology. So why not they enter into the HTA, a health technology assessment, like other products, like medicines or medical devices. So here we could have collaboration with other European countries and have all the data or the good practices or a common way to reimburse things like that.
Yeah, I think that's a very
And avoid fraud
interesting
phenomena.
and very hot topic also. Question? Yes?
Sorry. Just a comment
Yeah.
concerning the nutritional assessment after the legislation that we had last year. It's not happening really. It's not happening. It is true that malnutrition is underdiagnosed in Greece in inpatients of the hospital, but of course in the outpatients it is still more evident the problem. But there are just a few, or maybe one hospital in Athens, the Evangelismos, that really has this nutritional assessment risk quite many years. And me, sorry, I'm Dorina Cialvera. I'm working for a public hospital for thoracic diseases. We have just recently implemented this new legislation in a pilot basis because the truth is that we are very few. We are just 2 dietitians in a hospital concerning 700 patients. Well, yes, 700 patients. So the understaffing is more than anyone can understand that if it really be in application, this law, I think I should see 50 or 100 patients per day. It's not going to happen. So something must change dramatically so that we can really speak from truth about combating malnutrition, and not in general and ideally. Sorry, thank you.
Okay. We have. Okay. We'll do, and then, well, Anibal first.
Anibal from Portugal. We have same problem. We have few dietitians in primary care and in the hospital, but nutritional screening can be done by nurses. In Portugal, all nurses do nutritional screening from 5 years ago, and you have all nutritional screening implemented in every hospital. So it's so easy to do. So the problem is that when you find the patient with in risk, okay, you should go to a dietitian. But to do the screening, you don't need a dietitian.
percentages of malnutrition are too high, and from our pilot basis and in our congresses, which of course you are all welcome to come on December, we will announce some of the results. The number of patients that are under in malnutrition are too high. It's about the 50% of them and more. So it's too difficult to see all of them in 24 hours.
It is. Yeah.
Okay.
But this is the good thing, because until now we didn't know how much patients have in risk. Now you know that, and you can use the nurses to know that you have a lot of patients in our hospitals and in primary care that need to be seen by a physician or by a doctor or by a dietitian. So is that with that number that you can go to our ministers and say, we need to solve this problem? Because until now, you don't have any numbers. When I go to the minister 5 years ago, 10 years ago, I have any numbers. The only way you can change anything is getting numbers. So you don't get people, but you get numbers. And now you can go to the minister and say, please, I need help. I need people to treat these patients.
I think you're absolutely right. So what you don't measure, you don't know. Michael, and then Claude.
I would like to come back to the point that Maria had. She described that ICD 10 or 11?
ICD 10.
10 is used to qualify the reimbursement. As far as I know, in primary care, it is very uncommon to use diagnostic categories. It's not documented. It's tasks that are done. It's patient contacts, it's doing an ECG, it's doing a lab setting, but not a diagnosis. At least in Austria, there is no information what diagnoses are handled in primary care. So as the problem is in the hospital, you need to be able to document in the electronic system that you have asked the questions of screening. In primary care, it's much more basic. If you want to share the reimbursement, you have to find out which diagnosis is there, and you need the data. And so there is a lot to be done in this way of thinking that there is a diagnosis that is associated with an evidence-based treatment. And I think this is not available, at least for countries that I know.
Yeah, we have Claude, and then Nada, and then up here. Okay? Yeah, please. You need to push the button. Yeah.
We do not reimburse FSMPs in primary healthcare. So we need the disease because we reimburse according to the disease. That's why you use the ICD. Okay? Okay.
Okay, Claude.
Claude Pichard from Switzerland. So we have like 36 dietitians for 2,000 inpatients. Although it is seen as a rather large number of dietitians, it is strictly impossible to answer to the nurse and to the doctors when a patient is quoted at risk of malnutrition using the NRS. We have done it like in a hip replacement patient or in head and neck cancer patient. They all are at risk. So at the end of the day, you receive so many requests from the departments that is impossible to send a dietitian per case of malnutrition. We said before we need policy at the political level. We need protocols at the clinical level. We need to have the capacity locally, that is for each patient, to undertake the right treatment, not only about cancer or infectious disease, but also for nutrition. There will never be enough dietitians to take care of all the malnutrition cases.
Can I just follow up on that real quick and ask our IFAD and our dietitians on the panel here, what are the main drivers or issues that you're doing now to train other specialties to take care of any initiatives? You mentioned some, but can you just as a reply to Professor Pichard?
Well, we do some things, but they are not enough. And this is something that we have realized for some years now. The first step we can do as a European Federation is what we are doing now. So taking part in this multidisciplinary forum, like ENJA, ONCA, also working very closely with ESPEN. We have tried in the past, if I'm not mistaken, it was a joint attempt to get some funding from EU money to put in training programs for medical students or doctors or nurses, but that didn't go very well. We didn't get the funding. And now we have, as IFED, created a digital training learning platform. We call it IFED Learning. So we are trying to put more and more educational material there. But yes, you are right that we must do much more, and we must prioritize training of other health professionals and health and multidisciplinary teams in nutrition. The problem is that we are very few in most health systems. And the other issue is that there are countries where you have 0 dietitians in primary care. And these are most of the countries in the south part of Europe. Good cases are Scandinavian countries, and countries in the north. There in primary care, there are a lot of colleagues, and this is where you can more easily organize training for other health professionals and for multidisciplinary teams.
Yeah, we recognized the same problem many years ago at the Karolinska, and one of the nurses, Anne Odlund, who many of you know, perhaps, she initiated training nutrition teams on every department and got the nurses to do the bulk of the work because there are many of them, but they were trained by the dietitian. So this is what we need, that kind of thing, I think, is what we need to do. And now, okay, so we're here, and then up there, and then there. Okay.
No.
Oh, over there, sorry.
No. Thank you very much.
Next, yeah.
Thank you.
Sorry.
My name's Emily Walters. I'm the malnutrition officer at Baypen, and I was chief dietitian for one of the hospitals in the NHS. And I thought it might be helpful to share some of our experiences of screening. So although it's not law, it is our NICE guidance that you screen within 24 hours of admission to hospital. And I share your pain of trying to implement it into clinical settings. It's been challenging. One of the things we do is we try and have rolling programs of screening our nurses and also our healthcare assistants. And then what we've developed is pathways of care, because there's no way you can see all the patients. So depending on the screening score that they have, if it's a lower risk score, we have pathways of care within the ward situation that they can implement and start. And then we see the really, really high risk ones. So it's very much pathway driven to try and channel in the patients who really need to see us. The other thing we've done is developed an associate practitioner role for dietitians. So they're not registered dietitians, but they are trained, and they can deliver and importantly review a lot of the patients we might be seeing. And we're working along with speech and language therapy. And we also have that within primary care. We are by no means perfect at it, and there are still lots of gaps and challenges for the dietetic profession. But I wonder if some of those things might be helpful for you to consider. I'd be happy to share conversations and emails if that's of use for you going forward. Thank you.
Fantastic. Thank you very much. Nada?
Good day. I'm Nada from
Closer.
Slovenia. Yeah. Listening to all of...
Closer with the mic,
Closer?
please. Yeah.
Okay. I cannot eat it. I would like to share what we try to do in Slovenia. At first, I would like to address reimbursement policy because we simplified this. Regarding economic data, treatment of malnutrition is beneficial, cost benefit. So we have agreement with insurance that you diagnose a disease, malnutrition and cachexia. We are not going from disease, another like, I don't know, Crohn's disease. We are going to disease, which you have to diagnose because, right, these are diseases, malnutrition, cachexia, frailty, okay, or sarcopenia maybe. So we diagnose a disease and then we educate primary physicians, so far more than 600, in agreement with Ministry of Health and Insurance, that they can prescribe oral nutritional supplements for the treatment of the disease. They have to make a diagnosis. And Slovenia has 2 million inhabitants. This is quite a good share of primary physicians. And we don't limit the duration of treatment, because if you treat a disease, you also don't treat hypertension for, 3 months and then you stop. So we started from this point, physiological or pathophysiological point of view and from cost-benefit data, and it is working well so far. Of course, in hospitals, regarding all these issues with dietitians and so on, we organize clinical nutritional pathway, so everybody knows what to do. A nurse, a dietitian, and a medical doctor. And we have implemented this in our hospitals since 2016. We already presented this at ONCA meeting in Bled years ago. So these things are existing and they can be also reproduced. Now we are also forwarding medical specialization in clinical nutrition, because we have to have a physician who is responsible for this health discipline, like clinical nutrition, according to current knowledge. Like subspecialization in different specializations, but however, coming from the beginning, we have to treat nutritional disorders as diseases, to diagnose them, and as everybody know, we have to document this, and then things are a bit more simple than to go to different diseases and to limit duration of prescription, because we cannot treat just for some period of time. And what is very important, I must say, if medical doctor is not the leader of nutritional care, because we are treating diseases, we are responsible, and we are not treating malnutrition just with nutrition, but also with some other things, some drugs which are helping to nutrition, then this must be a very multidisciplinary approach. Thank you.
Thank you very much. I think you're touching on what comes back many times, is that we need to join forces and respect each other's specialties and work together. So last word.
We have Jana also.
Okay, last 2 words.
Yes, just to share my experience. I'm Anastasia, I'm working in the public health center. So we need to train the doctors, because whatever the doctors say, then the patient can receive the consultation from dietitians. So this is very important. And unfortunately, in our country, when they listen to the word nutrition, they just think of, okay, let's start a diet to lose weight. So they don't really know what it's about. And I really believe in education, so we might need to try to educate people from even the school, so to know what nutrition is, because I can say that people have started thinking. Some people, for example, I had a family who brought people with cerebrovascular disease to ask for advice, and this had to do with some knowledge of nutrition before. So maybe education at school and also train the doctors. That's my experience. Thank you.
We will be discussing that actually a little bit in the next session. Yes.
I would like to finish with a comment about the OP and the National Health Insurance Company. I would like to ask whether there is a programming on including dietitians and clinical dietitians in prescribing ONS, or in following the law that it was legislated in 2016 about the obligatory report from a dietitian in order to give the permission and reimbursement of a diet, an ONS or enteral nutrition, followed by the doctor's prescription, but with the recommendation by a dietitian. Do you think that it should be followed? How back are we in following that legislation?
Actually, I don't have a specific answer to give you. I wish things go on well because it's very important to have you people that you are professionals and you know your work better than us. That's what I was telling before. I hope things go on well and we see you in.
We are
in
always
the
by your
prescription.
side, whatever you need.
Why not? And we need people at the OP. We need dietitians to give us their knowledge and go further.
Thank you.
Okay, I think it's time to close this session. I'd like to give a big hand of applause for our speakers, but also to the audience. We'll have a break. We'll be back here at 2 o'clock, and we will have some very interesting stuff during that session. Some of the issues that were brought up will be covered.
Now we have a lunch here. You can all go on and serve. Thank you.
You have the camera on? Streaming? Okay. So, welcome back, everybody in the room here, and also to our online viewers. We're moving into the second session of the EU4Nutrition part of the meeting. And it's really a true pleasure to have an address given to you in just a moment. It's a recorded address from a surgeon from Hungary who is also a member of the EU Parliament. Andres Kulia will say a few words, and he will be on the video in just a second.
It is a pleasure and an honor to contribute to this essential event, even if I cannot be with you in person, something I regret. I would like to sincerely thank to the European Nutrition for Health Alliance and Oncopolicy Summit for the opportunity to share a few thoughts. As a medical doctor, former surgeon, and now a member of the European Parliament, I have seen throughout my career that nutrition is not just supportive, it is decisive. Proper nutrition care remains one of the most effective tools we have to prevent non-communicable diseases, including cardiovascular diseases, cancer and diabetes, all leading causes of mortality in Europe, placing enormous pressures on our health systems and economies. Investing in nutrition is therefore not only a medical priority, but a social and economic necessity. Nutrition's importance extends beyond prevention. In recovery, for example, after surgery, adequate nutrition support, especially sufficient protein intake, is crucial to enhance wound healing and reduce complications. In early childhood, good nutrition underpins physical growth and cognitive development. Later in life, it is a key factor in healthy aging, preserving independence and improving quality of life. However, today's malnutrition challenge is twofold. One side, undernutrition driven by poverty and food insecurity persists. But on the other hand, we face growing qualitative malnutrition. Diets high in ultra-processed food but low in essential nutrition, which also drives chronic disease. Both sides must be addressed with equal urgency. We are now at a crucial moment. New EU initiatives are being developed to strengthen nutritional care, integrating into broader public health strategies, promoting mental health, preventing cardiovascular diseases and diabetes, and addressing women's health needs. A life course approach is essential, recognizing nutrition's impact at every stage of life. The EU has a unique responsibility to set evidence-based standards, foster collaborations among member states, and drive coordinated action. But true progress requires partnership among governments, healthcare providers, researchers, and civil society. In these organizations, like ENHA plays a vital role. Through their advocacy, stakeholder engagement, and public awareness efforts, they help place nutrition firmly on both national and European health agendas. Finally, from my experience translating medical knowledge for the public, I know health literacy is key. When people understand the role of nutrition in their health and recovery, they are empowered to make better choices, and healthier choices build healthier societies. Thank you once again for your commitment to this important cause. I look forward to contributing our joint effort to put nutrition where it belongs, at the heart of the European health policy.
Yeah, I think this was another example of how important it is to get people from our communities, if you like, professionals who know what this is all about, also into politics to help spread the word. Now, we were supposed to have Eleonora Mellet here as well. She is another EU Parliament member, but unfortunately she has had an urgent medical issue, so she's unable to be with us today. In that situation, she still sent the message that when she recovers, she will be with us and help us in our struggle forward. So I think that was reassuring, and we, of course, send our best and wish her well. Our next presenter is going to be Konstantinova Budmaki, who is the board member of the European Patients Forum, EPF. And if everything works, she will be with us online. I can see you now. So very, very welcome. The floor is yours.
Hello, everyone, and thank you so much for this opportunity. Let me share my slides. One moment. Nope. Here's screen sharing. One moment. Can share and present.
Perfect. We see you very well.
Perfect. And thank you so much for this opportunity to speak on behalf of the European Patients Forum. And my name is Konstantina Boumaki. I'm a patient living with type 1 diabetes and a board member in EPF. And I'm truly sorry I couldn't be with you in person today, but I'm grateful to still be part of this important conversation on initiatives to unite patients in need of nutritional care. And so EPF is a pan-European umbrella organization that represent the collective voice of people living with chronic and long-term conditions through its 78 members and counting. Since its founding, EPF has been committed to ensuring that patients are not only beneficiaries in healthcare systems, but also active partners in shaping them. And EPF work in the field of nutrition, and this spans over a decade. In 2012, EPF co-authored and endorsed the publication Patient Perspective on Nutrition with the European Nutrition for Health Alliance and the Patient Network for Medical Research and Health, EGAN, and which brought forward patients' experiences and needs with food and nutrition as part of treatment and care. This was the foundation of our advocacy. This work led to the foundation for a memorandum of understanding with European Nutrition for Health Alliance and a long-standing collaboration through the Optimal Nutritional Care for All campaign. Despite resource constraints, EPF has tried to maintain its voice in the nutritional space through its relationship with the European Nutrition for Health Alliance and Optimal Nutritional Care for All, participation in conferences, and relying on its position statement on patient access to nutritional information and care. When possible, EPF has also worked to integrate patients' voice into clinical nutrition guidelines. And we also supported the revision of WHO's ICD-11 malnutrition coding and contributed to clinical guidance guidelines development via the European Society for Clinical Nutrition and Metabolism. And EPF position calls for embedding nutritional care into the continuum of healthcare with patients as co-creators. And even though in recent years our activities has been reduced due to resource constraints, we maintain our commitment to this area. Our legacy partnerships and policy stances are still relevant, and we see great potential to re-engage with initiatives like ONCA, particularly by ensuring meaningful patient involvement at both national and European levels. So, why nutrition matters for patients? For patients living with chronic conditions, nutrition is not just about food. It's a fundamental part of their treatment and well-being. Good nutrition can improve how the body responds to medication, reduce side effects, and even prevent complications that lead to hospital stays. It plays a key role in managing conditions like diabetes, heart disease, and cancer, while also supporting mental and emotional health, which are often overlooked. When patients have access to the right nutritional care, their overall quality of life improves. They feel stronger, more energized, and more in control of their health. But despite of all these benefits, malnutrition is often underdiagnosed and undertreated, particularly among hospital patients and those receiving home care. The ONCA campaign has contributed to pushing for national policies that aimed at malnutrition screening in healthcare in health systems, with 1 in 4 adult hospital patients being malnourished. Screening is the first step towards timely nutritional intervention. Yet, screening practices remain inconsistent across Europe, with some hospitals reporting rates as low as 31% and many patients not being monitored beyond admission. Systematic nutrition screening should be a standard component of chronic diseases management plans. This includes identifying patients at risk early and ensuring care pathways integrate dietetic support. Reimbursement remains a major barrier. Across Europe, coverage for medical nutrition is inconsistent and often inequitable, varying by region, condition, or even age. Better EU-level guidance and national reforms could help improve access to appropriate reimbursed nutrition support. And patients often struggle to make the right choice or to make informed choices due to poor labeling or lack of condition-specific dietary information. EPF supports mandatory front-of-pack labeling and the development of patient-friendly guidance tools, not just for the general population, but tailored to people with diabetes, celiac disease, cancer, and other conditions. Patient voices must shape the research agenda. Real-world evidence and patients' experience can complement clinical research in capturing the real-life value of nutritional interventions. Patient input in guideline development and lay-friendly summaries can improve both patient literacy and empowerment too, but also adherence to treatment and nutritional care. And of course, we continue to call for active patient involvement in healthcare decision-making, including in the area of nutritional care. This can be achieved through clear frameworks, capacity building for patient organizations, and political support for inclusive governance. EPF has already piloted these approaches through its nutritional cluster and is ready to build on the work. And of course, to truly advance nutritional care in Europe, we must move beyond treating nutrition as an afterthought and start seeing it as an essential part of patient-centered care. Patients are ready to be part of the solution, not just as recipients of care, but as partners shaping it. And of course, at EPF, we believe that by working together across organizations, disciplines, and countries, we can ensure that no patient in need of nutritional care is left behind. Thank you for the opportunity to bring the patient voice to this important conversation.
Thank you very much for that nice presentation. We will hold you so you stay with us so that you can be part of the discussion which we'll take after all the presentations. Well, now it's my pleasure to introduce to you Cristina Cuerda. She is well known to many of you. She's the General Secretary of ESPEN. And you're going to be voicing the ESPEN view on how to move nutrition forward, the approach for Europe, right?
Yes. Well, thank you, Ole, and thank you everybody for being here. And I think that.
New slides are coming up.
Mine slides.
I hope.
So I'm going to show you the ESPEN perspectives about how to approach nutritional care in Europe. And probably for those of you that are not very familiar with ESPEN, ESPEN is a scientific society that is, their main aims are to promote basic and clinical research and basic and advanced education. And of course, organize and develop clinical guidelines to harmonize nutritional care in different diseases. But on top of this, we are a multi-professional, multidisciplinary and international society. And I show you some figures. We can consider now that ESPEN is the most important clinical nutrition society in the world. We are composed by more than 3,000 members and include 70 pen societies that are included in our council. Even we are very influential and attract a lot of people. For instance, to the ESPEN Congress, to the annual Congress, we attract more than 4,800 delegates. These are numbers of the last Congress in Milan, coming from 128 countries. So it is quite impressive if you see in the map. How is ESPEN organized? The organization of ESPEN is quite simple. We have an executive committee and two main committees, one clinical committee, ECPC, and the scientific committee. Those committees run a lot of activities in the field of research and of course, education, to promote education, basic and advanced, as I mentioned before. We run an annual congress, and we have a very well-developed program of clinical guidelines with a portfolio of 19 clinical guidelines covering different topics, plus ethics, plus terminology. The society has 3 journals that are the voice of the society, but also collect a lot of information, scientific information, in the field of clinical nutrition. We have a very good database about nutritional health in the hospitals and in other settings in the Nutrition Day database, and also we have a very good database on intestinal failure. And in the last years, we have improved a lot the communication with our IT officers, so to speak outside of our box in which is really ESPEN. And we have also promoted in the last years charges de mission to cover different topics that for us are very strategic, for example, cancer, undergraduate education, malnutrition awareness week, and some initiatives, global initiatives such as the GLIM. We also have tried to address international organizations such as the WHO and have more interaction with some EU projects. But besides being a clinical society, we have trying to do networking, to work not only in the ESPEN Council and with continental or regional societies in the field, but also to address other scientific societies. Of course, IFAR are our natural partners, and we work together in many of the activities that I'm going to show you now. But in the last years, we have addressed many other non-related to nutrition societies, scientific societies, and I will show you some examples right now. Of course, we have also another step of collaboration with other organizations, such as the European Nutrition for Health Alliance and the ONCAN Network, and they are now probably our ESPEN voice for the address the parliaments and to address the political aspect of this society. We have addressed also in the last years WHO, and we have to thank our previous and our former chairman, Professor Rocco Barassoni, for these great advances that we have achieved in the last years. And of course, we are part of global initiatives. Many of them, we are really the initiators, such as, for instance, GLIM, also participating in GLIS, the human rights movements, the ICD codification, and also some development in dysphagia. Our main aim probably is to address and identify this neglected problem of disease-related malnutrition. Probably is the more important focus of our organization, of our society, because it is very prevalent. It is established in all the different settings, hospital, community, and nursing homes. It is multifactorial, and it drives to a lot of consequences, clinical consequences, but also decrease quality of life of the patients and, of course, increase the costs. And now we have really achieved a lot of information about disease-related malnutrition. We have a diagnostic criteria. We have the green criteria that fortunately were developed with a very international agreement. So we are now using this criteria globally, and these criteria have been validated and are feasible. So we are moving in a right direction. We have good data, also scientific data, supporting the value, really, of an individualized nutritional support that make a difference in the clinical outcome of our patients. So we have a lot of data, and we don't have to be afraid of nutrition as a less effective treatment regarding, for instance, the treatment of other diseases, such as, for instance, dyslipidemia or hypertension, because our treatment, medical nutritional therapy, is as efficient as these drugs. And we have more and more data about the cost effectiveness of this nutrition intervention. So we have a lot of data really now to address other scientific society, other administrators, EU, WHO, etc., really to work on this field. We were very happy last year when this review paper was published in the New England Journal of Medicine about malnutrition in adults. It was published by two very distinguished members of our organization. So really, I think this point of disease-related malnutrition is more and more in the agenda of everybody. But as I mentioned before, we need to work also outside of the box of the Clinical Nutrition Society. So we have tried in the last years to address other scientific society. And for instance, we have done a lot of collaboration with the Renal Association in Europe. We have worked with them in different things, for instance, these fact sheets, also organizing webinars with them, organizing review papers, also with ECHO, addressing the problem in cancer, also with the UEG in patients with gastrointestinal diseases, WONCA in primary care, and of course with the ASO, with the European Society of the Study of Obesity, establishing new criteria for the sarcopenic obesity, to identify sarcopenic obesity. In the second level of our networking interaction, of course, we have collaborated since the beginning with ENA and the ONCA network. We are part of ENA as a stakeholder since the beginning, and we consider now ENA as a ESPEN political arm. We are collaborating with them, of course, in the annual conferences, the big conference, and also the conferences that are usually, or the meetings that are usually held in the locally using the EU presidency in different countries. And we are collaborating more and more in the malnutrition awareness week. Probably this year will be a pan-European malnutrition awareness week, working together all the different societies with the help of ENA, and of course with all the collaboration from part of ESPEN. And we have collaborated with them in the elaboration of these policy papers, addressing problems in cancer patients, and of course this manifesto for health equity in the EU. But I would like to send you some messages about the development in the last years in the collaboration with WHO. As I mentioned before, this collaborative work started some years ago in 2019, and since then, especially since ESPEN is a non-state actor of WHO, it happened in 2022, we have participated regularly in the regional committee sessions in different countries. We have met with this WHO Europe representative in different moments during the ESPEN Congress, in symposiums organized by ESPEN, webinars organized by them. We have invited them to come to our meetings in Nice. So, and also this collaboration with WHO made us available the opportunity to also networking with other organizations that are also part of these WHO non-state actors. These are the last conference held in WHO Europe, in Israel, in Kazakhstan, and this year in Denmark. And I have to say that now, with the help, of course, of Professor Rocco Barazzoni, disease-related malnutrition is included in the agenda of WHO as a healthcare priority. And we have the opportunity to publish this fact sheet or policy brief with the help of Diana Cárdenas, that is also here, and I would like to thank, and also Rocco Barazzoni, to identify, screen, diagnose, and plan and monitor really this important problem of disease-related malnutrition. I must say that before talking with WHO in this direction, they were more focused on obesity field, on undernutrition in children, etc., that it was not the focus that Espen and many of us here have today. We have also other points of collaboration with WHO, on COVID, on education, on primary care. We work with them in this brief intervention to prevent non-communicable diseases at the setting of primary care and in the Espen position paper of primary care. Also, as a request from them on our tuberculosis paper, also addressing the problem of nutrition in these patients. And in older patients, they come to us and also participating in our Espen symposium. And in the last year, we have been working with them in this new fact sheet addressing sarcopenic obesity. So this is another collaboration. And the last one that I can mention is this alliance, the European Alcohol Health Alliance, also under the umbrella of WHO, in which Espen is collaborating also to put nutrition in the importance of the nutritional status in these patients with alcohol-related problems. Also we are engaged in the global initiatives, as I mentioned before, of course the GLIM, but the GLIM is growing, and we have now this paper that we have developed a few months ago about the 5 years update of GLIM. So we have now more data, validated data about the use of this GLIM, the feasibility of the implementation of GLIM, and also we have more data about how to address, for example, muscle mass as a phenotypic criterion, or address, for example, the etiologic criteria of inflammation. So we are paulatinely and progressively addressing the GLIM and establishing new areas of field of interest, for instance, ICU, how to address ICU, the GLIM consensus in these patients, or even in pediatrics in the future, we have to discuss. Of course, the GLICs, the same initiative also covering sarcopenia, but also we are very happy that had the opportunity to launch this Vienna Declaration. It happened in 2022. We promote that nutritional care is a human right, and this was very well accepted, and this declaration was signed by more than 70 PEN societies, including, of course, the 4 international societies. We are very happy to also to participate in the initiative and to work together with the international group for patient right to nutritional care, and we then elaborated this fact sheet, and we have elaborated different articles covering this topic, and the last one is this disease-related malnutrition addressing this problem in resource-limited settings. And we are also happy to be able to participate in this initiative of the changing in the classification of the ICD-11 addressing malnutrition in adults, because we were aware that the proposal in the ICD-11 were not in parallel with our clinical practice in the hospitals and in our clinical settings. So in 2020, yes, we sent a proposal under Swespen and with the help of the Swedish Agency for the Codification, and this proposal was approved and supported by more than 40 societies worldwide. And we are, I think, hopefully expecting that this will be finally approved, so we will have the way to codify malnutrition according to GLIM, probably in this fall or next year. And it will be very good, I think, because we will create awareness really of the problem and give visibility to disease-related malnutrition. Last but not least, we have also signed this declaration to improve the safety of persons with dysphagia, together with, of course, other organizations. And as I mentioned before, it is very important the communication. We have to speak outside of our comfort zone. So we have to speak to others. We have to speak to the lay people. And for that, I think the window of the Malnutrition Awareness Week is a very good opportunity that we don't have to miss. ESPEN started in 2022. And I want to thank the help of Silvia Tarantino and Maria Ballesteros, because they have been really very good drivers of this initiative, together, of course, with a lot of people in ESPEN. And we are now working also with ENA to organize this in a more European way. And so I ask you to save the dates for this new ESPEN Malnutrition Awareness Week in 2025. This year we will be focused on all the adults and work with the European Geriatric Medicine Society and also with the ERA Society on Nutritional Care and Surgery, together, of course, around the Nutrition Day and covering also some topics on education and medical therapy. So I think my message here is, as a scientific society, we are strong, but we are stronger probably if we work together with other people. Thank you very much.
Thank you very much, Christina. I think it's absolutely essential that we have the data and the science and the facts. And in this part of the world, we like to work with the facts. And they are providing us with that. So I'm happy now to present our next speaker. It is Alison Bate. She is from the WHO Athens office on quality care and patient safety. So the floor is yours.
Lovely. Hello, everyone. Yes, I'm Alison Bate. I'm from the WHO Athens office on quality of care and patient safety, and it's a real pleasure to be here today. Thank you very much to ONCA and the organisers for including us in this really important conversation and inviting us to speak. So what I'm going to be talking about is just giving you a bit of a background about our office, if you're not familiar with us and what we do, and our strategy around quality of care, and then kind of introduce nutrition into that and show you how it fits into our work and kind of weaves through our quality of care work, with a little bit of reference to what's happening at European level as well. And thank you to Christina for highlighting a lot of the collaborative work that's being done there. So this is us. This is our latest strategy, the Taking the Pulse of Quality of Care and Patient Safety in the WHO European region. We focus on providing country technical support on national strategies and frameworks to scale up successful interventions. We also are a bit of a research hub, providing innovation and knowledge on quality of care and patient safety. We provide policy analysis, and we spend a lot of time and do a lot of work around network building, alliances and stakeholder engagement. That's a huge part of our work as well. I should say that we work within the regional office for Europe, so that comprises 53 countries over a very large geographical area between the Atlantic and the Pacific Ocean. So quality of care for us, it comes down to three key things. Effective care that is evidence-based, and that's where a lot of our research comes in. Safety and people-centeredness. So it's about that individualized care that is respectful of individuals' preferences, their needs, and their values. And in terms of what this looks like in real terms, in a health service, it is a health service that is timely, equitable, efficient, and integrated. And often that last piece of the jigsaw, integrated, is one of the most difficult to achieve, with needing that really long-term view, that big picture planning, and that multi-sectoral action that spans across all health services within the system and across the entire lifespan. And if you haven't already been convinced by attending this conference on the importance of quality of care, well, there's also the economic argument, especially for high-income countries in terms of patient harm and patient safety. We know that that accounts for actually a very significant part of the healthcare spend. And so quality of care can be quite a cost-effective way of achieving better cost-effectiveness. And yeah, the main thing, though, for us is that we cannot achieve universal health coverage without quality of care. And I think this is a really good place to bring in nutrition, because it's very evident that without investing in essential nutrition actions, we cannot achieve universal health coverage. And equally, we can't achieve good nutrition for all without achieving universal health coverage. So the two very much go hand in hand, they're complementary. And if we look through history and look through modelling, we can see that over a fairly short period of time, within years, if we have a bit of a stronger focus on nutrition within our health services, we can save millions of lives. And on that cost effectiveness that we were talking about, so if I just go back to universal health coverage for a moment, the reason that nutrition is so important is that partly because of the cost effectiveness arm. And I just want to highlight that in reference to non-communicable diseases, because this is so prevalent that it's an incredibly high impact area. So nutrition impact through prevention. Our Tackling NCDs publication, the second edition, was published last year, and this highlights best buys and other recommended interventions for the control and prevention of non-communicable diseases. And I wanted to highlight this because a lot of those best buys that are highlighted in there, and by that I mean things that are not only highly effective but highly cost effective, a lot of those are lifestyle related and a lot of those are nutrition specifically related. So of course there's alcohol reduction, but there's also reformulation, public food procurement improvement, behaviour change communication and mass media campaigning to improve health literacy, food marketing restrictions, protecting and promoting optimal breastfeeding practices. These are all things that we should be focusing on kind of first and get right first to help drive down non-communicable disease rates and deaths. And then on the more kind of clinical nutrition side of things, which I know is where a lot of the interest is at this conference today, if we just go back to that meaning of quality of care, care that is effective, safe, equitable and personalised, if anyone working in clinical nutrition can see where the room is for improvement there. So it doesn't matter if we're talking about blood pressure management in a primary care setting or talking about a surgical patient, post-op in the hospital. It's about having interventions that are really evidence-based, safe and appropriate to that particular patient. And I just wanted to highlight one of the tools that we have that can help with this. So WHO E-Library of Evidence for Nutrition Actions, ELINA, for those of you who aren't familiar with, is a really comprehensive resource. On our interventions tab, it links out to individual pages on each of the interventions. And you can see on there what WHO's recommendation is and see a summary on the evidence base for that intervention and a summary on the cost effectiveness. And there's summaries on systematic reviews and things about that intervention as well. And so at a clinical level, this can be very useful, for individual use for clinical nutritionists. But it can also, it's actually aimed at helping countries to successfully implement and scale up nutrition interventions by helping to guide policy development and program design. So definitely want to go and have a look at if you're not familiar with it. And then I wanted to include another example of how we're trying to weave in nutrition to our quality standards. So this is our pocketbook of primary healthcare for children and adolescents, which was launched in 2022. And naturally, it's targeted at those working in primary care, but not necessarily people who are focused or spend all of their time working with children and adolescents or spend all of their time working in nutrition. But what we've tried to do is, what has been included in this publication is plenty of nutrition advice. And on there, you'll see screening for nutritional problems is on there as one of the things to try and help drive that into professions who might not otherwise get the training. And the final thing I really wanted to talk about today is an example of how we work with countries to implement quality of care across that entire spectrum, from disease prevention all the way through to care at all levels. And so Health IQ project is a project that we're working closely with at the office, Quality of Care Athens office in Greece. And excuse me, sorry. So this is about developing a robust methodological framework that we can use to improve quality of care across that full spectrum. And this is born out of Greece because Greece, in their 2021 National Development Plan, identified that they wanted to restructure their health system, and they recognised the importance of improving quality of care in order to do so. So some of the key objectives in this are recording and measuring key quality performance indicators, collecting and evaluating patient feedback, digitalization, and developing quality standards. And the reason that I mention this, even though it's focused on Greece, is that we plan for this to be rolled out across the European region. So the things that Greece is struggling with is particularly is rates of cancers and cardiovascular diseases. These are the leading causes of preventable deaths in Greece, and there's high rates of obesity amongst adults and also children. And I think countries across the European region can the things that come out of this are going to be applicable to the other countries who are facing similar challenges. And of course, I also mention it because these are conditions which are very much where nutrition really has a role to play. So I hope that gives you a bit of an overview as to who we are and what we do. And yeah, I look forward to the panel discussion. Thank you very much for your attention.
Thank you very much, Alison. Well, I have one more speaker. Last but not least, it's Radost Asenova. She is a board member of the World Organization of Family Doctors. So we had a big discussion about primary care in the morning. So here we have somebody who knows all about it. Welcome.
Thank you very much. Good afternoon, everyone. It's my pleasure and honor to participate in this international and interprofessional conference here in Athens, a city known for its long tradition in open dialogue and critical thought, and also the care for patient experience. And I think that the previous session is a very good example of that. So I'm pleased to share with you the European policy perspective on strengthening the role of primary care in the nutritional care patient's pathway. And I'll speak on behalf of WONCA, almost like ONCA, but it is WONCA, the World Organization of Family Doctors, representing over 120,000 family doctors across 47 countries, working through our national member organizations. I think that numbers are important, but our strength is not only in numbers, but in our networks and our special interest groups. So you can see here on the slide that we have networks related to different aspects. One of it is research. Why? Because we believe research is very important. We need a robust data based on primary healthcare settings if we want to know what is the reality, because we are in close connection with people. We also have an organization for prevention, EuroPrev, for quality of care, which was related to the previous speaker. And also we have a specific organization for those colleagues who are working in remote areas. And this is a very interesting and important issue. I think that for Greece it is also very important. About the special interest groups, I would like to pay attention only on two of them, the newly established, because they're closely related to the topic today, social prescribing, and also the lifestyle medicine. So they're really very active during the last 2 years. Nutrition matters in primary care because nutrition is a key to health across the entire life of our patients. And we as family doctors are in unique position to see patients across all stages of their life, from childhood to old age. And malnutrition is related to many non-communicable diseases, and I was listening very carefully the discussion, but I would like to open another issue, multimorbidity. This is something that is, let's say, the new norm for us as general practitioners. And I will tell you why it is very important. Because nowadays, people suffer from more than one chronic condition. And if we look into the guidelines, all the recommendations, they're focused on one disease. And we have to think about the person as a whole. And sometimes you know that the guidelines could give different recommendations. And we as GPs should to check everyone, to check all the conditions and to see that there is no contradiction among the recommendations. And also, we know that the nutrition is under-recognized in the management of those chronic conditions, so we have to pay attention on that. I decided to put on the slide these three, we say Wonka tree, which in a graphic way present the definition of family doctors, of family medicine. And I think that our core competencies were mentioned during the discussion in the previous session and even in that session. We are responsible for the first contact of care with our patients and about the continuity of care. That puts us in an ideal position for early detection of nutritional problems, the monitoring of condition, and also the management of those non-communicable diseases. But of course, we cannot achieve nothing alone, so for that reason, we really rely on collaboration with all of you. What the data tell us when we look into the Nutrition Day primary care pilot study? I was a little bit surprised to check it and to see that 14% of patients are at risk of malnutrition when we talk about primary health care level. And it is not a surprise for all of us that all age groups are affected. Additionally, from the data, I found that the screening is missing in many of the countries, which is, how to say, an opportunity to work together to overcome this problem. And of course, if there is no screening, of course, we can expect underdiagnosis and related to this, under treatment. We face lots of challenges in our daily practice. Limited time during the consultation, gaps in clinical nutrition training. It was mentioned many times during the discussion. We can't do it alone. Also, lack of reimbursement, it was mentioned from other colleagues as well, and integration of dietetic services. Another issue is the fragmentation of care. So no one can achieve something if he is alone. So we need to think to move from fragmentation to integrative care. Integrative care, yeah. So I can share with you many examples related to Wonka, but I decided that I need just to summarize that we are open for collaboration, and Konstantina showed some of the documents that we were part of development. Also in the previous presentation, I saw the manual which is for the non-communicable diseases, and our colleague Mehmet Tongan was part of the development of this issue. What we are trying to do is to organize lots of webinars to share the experience from different organizations and also from best practices. I think that diversity is not a barrier. We have to use this diversity and to use the good practices to implement in those countries where something is missing. I come from Bulgaria, and I can tell you that the situation is almost the same like in Greece when we think about the non-communicable diseases, mortality, morbidity, and so on. But congratulations, you achieved a lot in the field, and I'm really impressed by this forum because you managed to, to bring the voices of politicians, of clinicians, researchers, educators, which is the really big advantage. And it's a good example how interprofessional and interdisciplinary collaboration could shape the future. So I took my home message, by the way, for my country from you. We all know the key elements, and they were also mentioned. And when we think about primary care level, I would like just to point out some of them. For sure, we need routine screening for malnutrition, but as family doctors, we need simple, validated tools. I mentioned about some of the barriers. Brief interventions and lifestyle counseling integrated into chronic disease management plans, referral pathways, but also we need to be supported by clear protocols if we want to follow the regulations. Monitoring and follow-up as part of long-term care, especially in vulnerable groups. We have to think also about people with frailty. I think that one of the colleagues mentioned it, because this is again a huge problem related to aging population. Many people will face this problem. And training and CME, of course, for GPs in the field of nutrition. And to strengthen the nutritional care in primary health care level, we need to integrate it into our routine primary care. I mentioned already the simple validated screening tools to support local and regional collaboration among family doctors and other healthcare providers, to provide relevant ongoing training for family doctors, but I would like to mention not only family doctors. I think that the minister mentioned undergraduate education as well, because if we focus our attention on the undergraduate level, then all the clinicians will be aware about the importance of the issue, because we all know that somehow it is neglected, and patients sometimes would like just a simple drug to solve their problem, because no one would like to invest efforts in healthy habits and lifestyle changes. So the role of WONCA is that we are really showing our commitment and willingness to participate in any forums that could raise awareness of this problem. We try to empower our member organization and also to advocate for better health of our patients, and to move towards a shared agenda. We need common goals, and I decided and I've heard that we are talking in the same language, all of us. So what is needed just to combine our efforts and to try to be more visible in front of the policy makers, because we see a future where nutrition is embedded in our routine practice, and we'll continue our collaboration with all the networks in that field. Improving nutritional care across Europe can't happen only with good intentions. They're very important, but it's not enough. So for that reason, we need strong leadership. In ESPEN, we can rely on that to force us, because I saw so many data. And also collaboration across disciplines. And being a GP, of course, I believe that we are the one that could contribute to the success of our common initiative. So with that, I would like to reaffirm you about our commitment to continue to work together for better health of all of our patients. Thank you very much.
I'm going to ask the ladies who are present to take seats here. And we have Konstantina also with us online, I hope. So, well, what a panel we have, if you think of it. We have the patients, European representative. We have a very influential organization who can influence politicians. We have the people, the doctors who actually see the patients from the beginning to the end, so to speak. And we have the organization that represents the knowledge, the science. So the floor is open for the discussion. And I think, well, let me just start up. We're going to do these keys later, actually. Don't worry. I can understand you can't barely wait to see those key messages, but you just have to wait a little bit. No, but seriously, if I just start with WHO. So, Alessandro, what is your main barrier to getting your message? I mean, you have a lot of knowledge. You're publishing things. To get it out there, to make things happen, what do you recognize as your main barriers to really reach the goals that you were talking about?
I think I think it's this joined upness, and we're getting much better at it. But that jigsaw puzzle piece I talked about of that integrated care and integrated approach from bringing people together is really difficult to achieve, especially with so much international and national kind of state of flux at the moment. I think that's a real challenge, but we are getting better, and it's very much recognised as a difficult problem now, and something that I think all organisations are really trying to tackle.
Radost, you mentioned education and training of your colleagues as one of the issues. What would you like to see happen from ESPEN? Could they deliver an LLL program for maybe you already have it, I don't know, for primary care?
Or no?
Yeah.
Now it's open. Yeah, I think that education and research is a part of our business card. So if we want to achieve something, we should rely on robust data and also on qualified family doctors. The problem is that, we are responsible for any kind of health problems of our patients, and we do not have enough time to cover everything in detail. So for that reason, we rely on the collaboration with other networks to work together and to educate family doctors. But as I mentioned, if we focus on the undergraduate level, then it will be much easier for each specialty, because although I rely on family doctors, I can tell you that not only family doctors, but any kind of specialists need such kind of training and solid skills.
That brings us to basic education. Christine, I know you've been involved in that. Maybe you'd like to tell us a little bit about what should be done there.
Yes, well, thank you, Ole. Yes, indeed. I think in ESPEN we have been working a lot in the last 5-6 years on developing nutrition education in medical schools, just to identify learning objectives and the critical mass of knowledge. Not a lot, because we know that the time for teaching at the university is difficult, but just to create really awareness in these medical schools and in these students, and try to address the main topics that we identify 21 topics. So it will depend on each university. It is not easy, but we have developed a material to cover this very easily. You can download for our webpage. Tomorrow we will have a workshop on this topic, so you can attend, and we will give explanation about this. And of course, this can be offered to other organizations to share. Besides that, of course, in ESPEN we have a very well-developed LLL program that covers more than 128 modules or even more. covering different topics, diseases, and addressing the nutritional problems and how to address nutritional therapy in these different diseases. So I think, of course, I am very open to collaborate, of course, more with WONCA, and we are very happy to offer what we already have.
Perfect. Definitely we need to use such kind of resources because they're valuable. Yeah, thank you.
So let me just ask the same question to Konstantina. What do you think patients would need? What kind of education in nutrition would they need? What are you wishing to have?
Well, I'm hearing all these discussions, which is very interesting, but I think it needs to start from the start. So in schools, we need to follow Finland strategy, the school meals for all, that they have implementing very healthy meals in all the schools, pre-elementary and elementary, which is great, and they have seen some results. So if you educate the children, then they follow and they are having a more healthy lifestyle, because I grew up in Greece. In schools, we have very junk foods. I don't know if any of those people here can relate, but very junk foods, that this is very unhealthy lifestyle. And of course, all these organizations need to work together to a common strategy, to have a common plan, and then implement strategies into governance, into countries, to have projects for educating patients, because these will help to their health. And it needs to follow some to support the ONCA teams in implementing EU policies that are relevant for patients, to promote the integrations of nutritional care policies into national health plans, and to organize a lot of common discussions and roundtables.
Okay, please, it's wide open for discussions. Yes, Teklan. Closer, perhaps?
Closer, perhaps.
Yeah.
Yeah, there we go. Declan O'Brien from the British Specialist Nutrition Association. It's maybe a question to Alison, but also to Christina, and it relates back to the ESPEN conference last September, if I recall correctly. There was a WHO speaker who mentioned that disease-related malnutrition was going to be declared as a fundamental principle, I've forgotten the terminology, of the WHO, and that there would be an announcement in this September. Just wondering, Alison, Christine, if you can provide us with an update. Thank you.
I'm afraid this isn't something that I'm fully aware of, working at the Athens office, specifically more on quality of care, but maybe there's something that you know happening at the European level that I'm not aware of.
I show the policy, the fact sheet that we developed together with the WHO. Of course, we are working with them in different actions. So now we also move to sarcopenic obesity, to alcohol-related disease. So we are moving with them, but I think nutrition is now in the agenda, and malnutrition in different aspects. So in the end, we are covering the same topic. So I think, I don't know, maybe Rocco can update because he's our officer in the WHO. Maybe he has more information. Okay, so this is what is happening really.
Okay, well, I have a question for Konstantina again. Just your thoughts about who will the patients listen to when it comes to nutritional advice?
This is very interesting.
Just your guess and your feeling.
I think, in my personal opinion or the population opinion, because my personal opinion would be that I would, if it starts from the family, from the young age, it needs to be like a system, an everyday routine. But the doctors need to have the key role in this education and in this in this discussion with the patient to teach them, to educate them all the benefits and why they need to follow a good nutrition
So you're saying the doctor?
Yeah.
Okay. Well, this is really important that we take this on board.
Can I disagree?
Yeah, okay. Yeah, please.
And this was actually my question that I wanted to ask to Konstantina.
Yeah.
I don't think they will listen to the doctors, honestly. What especially younger patients will listen to is the internet, honestly. And that was my actually question. Do you, as European for Patients Forum, do you engage in internet, social media campaigns, educational campaigns, or do you plan to? Why am I asking? We did this kind of campaign for one of the companies back in the years. It was early 2020. These were actually the first weeks of COVID. And we did a non-branded educational campaign over the internet, in social media. And throughout 1 week, we had about 3 million views. And then we did a post-campaign questionnaire on the internet, and about 500 people responded, and only half of them were medics. So half of the people that watched the campaign, or at least responded to the questionnaire, were non-medics. And actually, in their self-evaluation before and post the campaign, their level of this basic knowledge about nutrition increased for about 30%. So this is my question, because, I mean, we don't have the range, none of us has the range that the internet has. And if we want to do something more, we have to go not in 100 views, we have to go into million views to be able to get to some people.
Yeah. Can I ask, because I don't have a picture, from what organization are you? Who do you represent?
I'm a surgeon.
Okay, so your campaign was addressing the general public, right? Because we have a different discussion if we're talking to patients, and we have a different discussion if we're talking to the general public. Because the patients, especially with chronic diseases, they have a very special bond with their doctors, and they're listening to them. Of course, we need to have another discussion, which is a completely different topic, about the patient-doctor relationship, which needs to be restructured and redefined. But a chronic disease patient follows the instructions of the doctor for their health, because they have something that they need to control. Especially for type 1 diabetes like me, the nutrition plan was number one. I was diagnosed 20 years ago, and I needed to have like a specific grams every 3 hours meal plans, the mixed insulin system with syringes for many years. And this was only with the discussion with my doctor. I couldn't, of course, the internet didn't exist, but different eras. But the general public would search in the internet, and some patients would look in the internet. But this is a very a necessary evil, I think.
Okay.
We can search some topics to the internet, but then we don't need to how to say, sorry, my Greek mind is here now, but we don't need to have the internet as opposed to talking to our doctors. We can search some information in the internet, and then we can talk to our doctor to have specific instructions for our health plan as patients. As the general public, of course, we can look if
Absolutely, I agree. Yeah. But let me tell you the background of this whole campaign. So one of the nutrition companies, they did their own research, and the effect of the research was that even if they wanted to do any educational campaign, so the number of people interested in the topic would be like 0.1% of the population, right? So completely senseless from the point of view of the company. So what they thought was that, hey, by reaching the society, we will also reach the carers, the families, not only the patients, because you have a certain group of patients. You're absolutely right. You're a group of people who are bound with their doctors, right? But speaking about malnutrition or nutritional risk, we're speaking about getting to the people who are not familiar with the problem. So probably if we have an 80-year-old lady who's frail and doesn't want to eat, we will never reach her in a traditional way. That's impossible. But with such campaigns, with such large-scale campaigns, we can reach her daughter or her granddaughter or someone who will see, hey, there was a guy who said that you might be malnourished.
Yeah, but from certified organizations, like medical organizations, they can have campaigns through the internet, but from certified bodies. They can be from random person like Constantina on a Wednesday uploading an article saying that you need to eat at 7 a.m. and then don't eat for the whole day because you're good if you eat in the morning, because we've seen so many bad things in the internet. So people need to have access to information from certified bodies and from people that they know what they're talking about. And internet is a good access, of course. People now are always on their phone, but it needs to be from certified bodies.
Okay, thank you. We have another comment question.
It's a comment question for Constantina too, because on your question about nutritional advice, and of course doctors will have the diagnosis, but the nutrition plan is administered by the dietitians, mostly, preferably.
Yeah,
okay, in cooperation with the doctor, of course. So I understand the relation, but most of the times maybe doctors don't have the time to have the education to the patients. So the dietitians have this huge work to do.
Of course, it's the healthcare professional team, and dietitians are in the healthcare professional team.
Okay, so we have one question over here, all the way up. Manuel?
Thank you. My name is Manuel. I came from Spain. I'm a patient. I was board member of the European Patient Forum also. And my question is about the debate, because as a patient, I think that the most important thing is the co-responsibility of the patients. So to achieve this co-responsibility, clinician, doctor, nursery, dietitian, everyone needs to be focused on learn and teach patients. And my question is because in the first session is everything the education for clinician, education and the patient. Where is the patient? Because for me the most important thing is the patient. Constantina talk about the children. I was very young, 4 years old only, and now 24. 25 only, no more. A lot of years before, I'm here because someone educated me to take my own decision and share decision with the professionals. So I think that the internet is very good, but it's not confiable, because in internet is everything. Do you know that Google is Dr. Death? Do you know? Because it's a lot of things. They have good, bad. So maybe internet is not the best. We have made a study in Spain that the second font of investigation. What about my diseases is internet. After the clinician, the specific, the hospital clinician. So, very careful the information. We need to provide to patient confiable information, confiable websites from clinicians, scientific society. I don't know what do you think about how to teach patient from the scientific society, from the primary care or whatever, because you are very a lot of things from the WHO, and Constantina from the perspective of the European Patient Group. Thank you.
Yeah, that's a good question. Why don't we just move through the panel? Christina, do you want to start?
Well, I agree with you, Manuel, that patients should be included, of course, and this patient expert also is included in many centers, I think, because you have also the voice. So I think you should be taught also, and of course, regarding nutrition, you should know the consequences of not receiving appropriate nutritional care in each of the diseases. So I agree with you that we should involve more patients in all the organizations, I think, leading with this topic of nutrition.
Okay. Valdast?
Thank you very much for this raising this issue, because if we go back to one of our core competence as family doctors, it was exactly patient-centered care, which means that we rely on our continuity of care with patients, and also you mentioned autonomous person. I mean, this is something that makes us different from other disciplines with doctors in the hospitals, because we rely on our relationship with the patients to educate them, to give all the information, because if there is no trust and mutual respect, we cannot rely that our recommendations will be followed by the patients. And also, one of the advantages that we know the background of the patient. So we know the family history, and we can expect some conditions, and we need to have a proactive approach and to focus on prevention, something that was also mentioned during the discussion. And I rely on our really mutual respect and trust with the patients. Having experience like a GP for 25 years, I can see many things that were changed from the beginning of the healthcare reform in my country and nowadays. I think that we are really partners with our patients and they trust us. So for that reason, I a little bit disagree with my colleague, because people, our patients are going everywhere, but at the end they're coming and they ask us, tell me what to do, because I receive different recommendations, and someone should combine all the information based on the background of the patient.
Okay. Alison, do you want to reply quickly on this?
Thank you. Yes, just to agree that misinformation and across the internet is very much an issue that we see not just in nutritional care but across the spectrum. And we at WHO at European and global level do have tools available for quality within the quality teams to help try and combat this. Yeah. And so I would refer you to those to have a look if you're interested.
Great. Konstantina's last answer on this question?
No, I completely agree with everything said before me. And okay. I think the conclusion is to work together with the patient community, with the healthcare professionals, and to have a very good collaboration, to have certified instructions and education to the patients and to the community in general.
Okay, thank you. We have last 5 minutes. We have Elizabeth now, and then Stefan.
Yes, very shortly, because Stefan also has a question. Well, talking about the communication with the patient, I think you can't stress enough the importance of the person-centered perspective, because healthcare personnel have the knowledge how to do it, why do it, but the patient has the perception, and their own goals, hinders, whatever. So if there should be an effective treatment in terms of nutrition, especially I think, because food is so very individual, how you put it on the plate, what you put on the plate, when you eat it, and so on. We need to be very humble and start all the discussions to see what the patient is and what is important for the patient. And then it doesn't matter so much who is the one who delivers the information. But talking about nutrition, probably nutritionists and dietitians are quite useful.
It's interesting because an old Danish philosopher, Kierkegaard, said many years ago, if you are going to lead somebody, you better start by finding them where they are. Stefan.
Yeah, complementary to what Elizabeth and Konstantina just said, I think the patient needs to be strongly involved but trusting the HCP. The problem is, who is a nutritionist? Is that a physician who did all this training in nutrition, one who specialized in nutrition, a dietitian with 5 years of study, one with 2 years of study, a scientist, a charlatan posting on the internet? That's very complicated to find somebody you can trust. And I remember from a survey in the US, most physicians think that nutrition is important in Crohn's, in IBD, but most of them don't know how to do it.
Yeah. We had one more question up there. Yeah.
I'm from Italy. I'm a dietitian. I'm here today to represent the Italian Association of Patients with Inflammatory Bowel Disease, and I just want to share important data that we have collected through survey with patients. This survey have indicated the level of food literacy of IBD patients, and 70% of IBD patients have insufficient level of food literacy, and 15% of these patients were not able to correct interpreted food label. So I think both data are very important in the way that we already said about the importance of nutrition education, not only prevention or treat malnutrition, but during, especially in remission phase, educate patients, improve quality of life, and self-management of the chronic disease that patients have to live within.
I think that was a very wise last word on this discussion. If the recipient of your information don't understand what you're talking about, we're lost, right? So I think that's a good point. Okay, now you have. First of all, I'd like to thank our panelists here for fantastic presentations. And also for all of you to sharing the discussions here. I'm going to finish by what you've been waiting for all day. If we can get the slides on. With the 7 EU4Nutrition key policy initiatives that we're driving right now. We're organizing high-level EU policy events to launch the EU Malnutrition Awareness Week, support ONCA teams in implementing EU policies that are relevant for patients. That's what we've been talking about all day. Engage with the European Commission, Parliament, and Council, all of them, on nutrition. Integrate nutrition into broader EU health and social agendas. That's also something that we have been talking about, getting good ideas. And elevate nutrition in European research programs and funding priorities. We just heard the data that many of the nutritional treatments are at least as effective as some of the medication that we're giving. And then build an EU4Nutrition task force. So those are the 7 key policy initiatives that we're running within this campaign. We will now have a break, and I'm going to ask Joost, our master of organization, to tell us what's going to happen next. It's going to be the photographing of the group, and You're going to tell us all about how that is going to happen, and we're going to be back here at 4:15 for the next session.
Thank you. So the streaming will end here, and so we say goodbye to everybody online. Maybe we can wave, say goodbye to them. Thanks that we'll be here. And our next stop is the front of the building, the main entrance for the group photo. Coffee's still closed, drinks are still closed, so you can get them right after the photo. So first priority for everybody, please go out smoothly and swiftly so we can get on the photo and you'll have your coffee as soon as possible. Yes? And then after the coffee, we'll be back at 4:15. Thank you.